네, 2013
Distinguished guests, may I have your attention, please? The conference will begin at 10 a.m. The conference has moved online to prevent the spread of the virus. Please join us on YouTube to watch the conference. The conference is streamed live on YouTube. We have 2 channels. You can watch the conference on the Korean Seoul-si YouTube channel or the English Seoul City official YouTube channel. So please select the channel of your choice to join us. Also, the conference provides text and sign language interpreting for the underserved. I have one more announcement for the Q&A session. As the conference has moved online, we will receive your questions via YouTube. If you have any questions about the presentations, please upload your questions on the YouTube chat box for the speakers to entertain your questions. We also ask you to participate in the Watch the Show live event. Take a photo of yourself watching the conference and upload it to your SNS using the hashtag for the event and upload it on the official website. Once the 2-day conference is over, 100 viewers will be picked to win coffee coupons of Starbucks. Details of the conference are available on the official website or by scanning the QR code on the screen. We will see you at 10 for day 2 of Seoul Human Rights Conference 2020. Thank you. Distinguished guests, welcome to Seoul Human Rights Conference 2020, Day 2. Thank you very much for joining us in person and online from home and abroad, despite your busy schedules. My name is Kim Kyung-mi, MC of today's conference. The Seoul Human Rights Conference 2020, which marks its 5th anniversary, has brought together experts from home and abroad to exchange vibrant ideas under the theme Human Rights in Crises and the role of Seoul Metropolitan government. Yesterday, we had the opening ceremony as well as the plenary session. And today, which is day 2, consists of general sessions 1 to 3 and theme sessions 1 to 3. And I would like to extend my gratitude to all the viewers who joined us yesterday. And as you might have expected, this year's conference has moved online due to the pandemic to ensure the safety of the participants. It is a shame I cannot meet you in person, but please join us online and stay with us until the end of the conference. And please join us in listening to the insights of the experts of the local as well as central governments. The conference is streamed live on YouTube. You can watch the conference on the Korean Seoul-si YouTube channel or the English Seoul City official YouTube channel. So please select the channel of your choice to join us. Also, the conference provides text and sign language interpreting for the underserved. I have one more announcement for the Q&A session. As we have moved the conference online, you can ask the questions via YouTube. If you have any questions about the presentations, please upload your questions on the YouTube chat box for the speakers to entertain your questions. We also ask you to participate in the Watch the Show live event. We have many viewers who are viewing us right now live. So please take a photo of yourself watching the conference and upload it to your SNS using the hashtag for the event and share it on the official website. 100 viewers will be picked to win coffee coupons of Starbucks. Details of the conference are available on the official website, or you can just scan the QR code on the screen. The studio was disinfected this morning and is operated safely in accordance with the quarantine guidelines. Please forgive us for keeping the masks on during the conference to observe the safety guidelines. We will now begin theme session 1 of the Seoul Human Rights Conference 2020, titled Human Rights and Health of the Elderly in the Age of Health Crisis. This session aims to seek measures to address the challenges faced by the poor older persons who are often left in the blind spot due to the shift to a contactless lifestyle. This session will be moderated by the moderator. And once again, if you have any questions about the presentations, please upload your questions on the YouTube channel. And I'm sure that the moderator will try to answer your questions together with the speakers. So this session will be moderated by Professor Lee Kyung-soo of Yeongnam University. Professor Lee is Assistant Professor of Yeongnam University, College of Medicine Advisory Member of Daegu Center for Infectious Diseases Control and Prevention, and Committee Member of Epidemiologic Investigation of Daegu. The floor is yours. Good morning. My name is Lee Kyung-soo, moderator of theme session 1 of the Seoul Human Rights Conference 2020. Thank you for joining us online. So thank you very much for your time. The session consists of presentations and a panel discussion, which will be followed by a Q&A session. First of all, let me introduce the speakers and the panelists. Director Lee Sang-hyun of the General Public Health Service at Ilsan Hospital. Next, Ms. Nina Monrad-Boll, health counselor at the Embassy of Denmark in Korea. Next, let me introduce the panelists. Professor Jeon Yong-ho of the Department of Social Welfare at International University. Professor Jang Suk-lang of the Red Cross College of Nursing at Jungang University. Professor Im Jong-han of Inha University College of Medicine and Chairman of the Healthcare Council at Korea Community Care. And he has also planned this session, so thank you very much for your effort. Last but not least, Ms. Kim Jong-hyun, Research Fellow at Seoul Welfare Foundation. Thank you very much for joining us today. Now, without further ado, we will hear the first presentation delivered by Director Lee Sang-hyun of the General Public Health Service at Ilsan Hospital. Director Lee graduated from Yonsei University and received PhD in Korea University and also studied in the University of North Carolina. So he was a visiting scholar at the University of North Carolina, and he is also Director General of Public Health Service at NHIS Ilsan Hospital. The floor is yours.
Thank you.
세상은 두 부류로 나눌 수 있다고 하죠.
Well, it is said that we can divide the world into two groups, older persons and older persons to be.
의사입니다. 여기 오신
Well, I am a doctor and also an older person to be. And we all are here.
시대의 노인 건강과 인권인데요.
The title of my presentation is Human Rights and Health of the Elderly in the Age of Health Crisis. Let's have a look at this subject all together.
왜 보건위기가
The health crisis.
위기 아니에요?
Why a public health crisis? Haven't we had any time that we hadn't have a public health crisis?
어떻게 많이 익숙해지나?
Well, we call this era a contact-free era,
우리나라에서 더 활발한
and that makes us to be shrunken. But we have some more active
회의를 하게 되는
activities online. And when holding an international conference virtually, one of my colleagues who are now in the States, he can freely join us online. And friends gathering, we can
온라인으로
have
만나서 이제 얘기를 합니다. 직접 만나지
our
온라인으로 하죠.
meeting online because we can't meet in person, and sometimes we have more conversations than we did offline. And there are advantages of having online gatherings, but there are people excluded from this, and there are certain age groups excluded from this phenomenon.
이렇게 볼 수 있습니다. 전국 취약계층을 가장
Well, and this shows the vulnerable class of digital informatization, the disabled, and the elderly, and the people in rural areas. And these are the groups what we call as vulnerable.
정보의 수준이 떨어집니다.
But amongst all these groups, the elderly is the least in terms of digital informatization. And it's only 64%.
우리나라의 휴대폰, 스마트폰 안 갖고
The penetration rate of Korea is very high. More than 90% of the whole total population has mobile phones, but for people of 70 and over, the ratio drops down to 30% level. And online is one matter, And the contact in person is another one. And you may have seen this notice. And the family visit is strictly forbidden for the prevention of the infection. Well, it poses lots of problems. For me as a doctor, it's a great problem because there's no way for me to know previous conditions of the patient. Even if I try to ask questions to the patient and to family members, it's not practically possible. And this is also another challenge for patients' families because they cannot know the current condition of the patient, and that poses problems and misunderstandings between medical staff and family members. That's what we have as major concerns in an era of COVID-19. So in the age of aging society, well, if you look back on the past, and a lot of things had happened during the past 45 years. In 70s in Seoul, the life expectancy was only 62, but it has grown up to 82 in 2020, and it will go up to increasing by 20 years for the past 45 years. And this yellow means 2050. And in 2017, we had around 14% of 65 and over population, but we will be the first ranked country in the world with the highest aging pattern. And also, we will be almost at the same level as Japan because of this ratio of the elderly will go up to by 5 times. But when it comes to the average of OECD, it has increased by only 2-fold, which means that, well, OECD reports said that Japan has been the first ranked country with the highest number of the elderly over 80, but that place will be replaced by Korea. And this phenomenon comes with other difficulties as well. In case of Korea, we have a higher rate of the poverty of older persons with a high rate of suicide. Then what's the main reason of committing suicide for the elderly? Well, economic reason comes first on top. But the second main reason is health issues. So when you approach to solve issues related to the elderly, then you have to think about economic and health issues. Then what are the human rights and the right to health of the elderly? In 1948, the UN adopted the Universal Declaration of Human Rights and also UN's Declaration of Old Age Rights. And in the 1982 World Assembly on Aging, UN adopted practical guidelines with the details to practice. And in 1991, UN has also adopted 5 principles for older persons, including independence, participation, care, self-fulfillment, and dignity. And these basic concepts have come to mind in people. And in 2002, Madrid International Plan of Action of Aging was adopted to promote health and well-being into old age and to ensure an enabling and supportive environment for a robust and sustainable aging society. Then how about the Korean policies? It was since 2007 and 2008 that Korean government has started to have interest in older persons' human rights. In 2007, Korea established national human rights plans of action with some principles such as the principle on respecting human rights, the principle on equality and prohibition of discrimination, and the principle on democratic participation. And also in 2011, Dementia Management Act was enacted to treat better the people with dementia, and they were community-based prevention and management acts. dealing with convenient and safe diagnosis and treatment and care, because this should be the burden for family members. This act also stipulated some details on the reduction of care burden for family caregivers and support through research and statistics. The National Human Rights Commission of Korea has categorized the scope of older persons' human rights with its report on human rights of older persons, and it is composed of 6 areas: care for health, basic living conditions, income, employment and labor, integration and participation in society, and last but not least, dignity and safety that is related to right to life. So we try to combine these principles from one another. And as for the income, income and the food, clothing, accommodation is related to the basic rights to life. And the income categories are for guaranteeing basic living conditions, and the employment and labor and social participation and integration are for an active and robust lifestyle of the age. Then, out of these multiple action plans to promote the human rights of the older population, what should serve as the priority? If you look at the 2017 National Survey of Older Persons, the priorities in promotion and protection of the elderly's human rights, the physical health improvement ranked the highest. And as mentioned earlier, when approaching the human rights of the elderly, you have to see 2 pillars of health and economy. And we will focus on the health side today through my presentation. Then where should older persons be? Well, we've conducted a survey to figure out where mainly the older persons live in Korea. Well, in the year 2015, Seoul was 12.6% and Gyeonggi-do is relatively low with 10.5%. But if you look at Jeollanam-do, Jeollabuk-do, and Gyeongsangbuk-do regions, it goes averagely over 17% level. So how to support these older persons in these regions is a continuous question that we ask ourselves. And in those areas, we also have conducted a survey to see how many multiple diseases are observed from older persons in these regions. And it has doubled during the period, but as you see here, it got quadrupled on the graph. So multiple diseases and multiple complications are very common in older persons, and they pay a lot for drugs, which is one of the main issues of the elderly in Korea. We are one of the high countries in terms of drug prescription of OECD member countries. This is the biggest medical task given to us. Well, many prescriptions is also a problem, but also the more you take drugs, and then the more you tend to be dependent on them. And as for the
관리가 어떻게 국가적으로 시스템화되어 있냐에 따라서 이런 부분들의
painkillers. Well, we are not that high in using those drugs, but we are quite good at treating and managing the prescription level. But as for the chronic complications, it is highly educated. For example, for the treatment of cancer patients,
노인에서도
But as far as the elderly is concerned, to kill the pain, sometimes it is recommended for older persons to use these painkillers. So that is another subject that we have to pay attention to. And as for dementia, dementia is one of the highly noted illnesses in older persons. And we have around 39 people out of 1,000, sorry.
그래서 얼마 전에도
And that's why the use of antipsychotic drugs become again another challenge in dealing with older persons, and especially in care facilities. It is said that the usage of antipsychotic drugs is too high, but if you look at the average of OECD countries, we are relatively low being compared to those countries. And also, when it comes to benzodiazepine, which is often prescribed for anxiety, it is also falling below the average of the OECD countries. But if you look at the record of 2012 at your right side, we are quite high. Meaning that long-acting benzodiazepine is highly used in Korea before, but it is also turning into another direction. But anyhow, antipsychotic drugs and benzodiazepine prescriptions should be monitored, and they also have to be equipped with the treatment guidelines.
그 노인 환자들이 지금 갖고 계신 쪽에서 이분들이
And
많이 이용하게
among the elderly, long-term care facilities and staff is of utmost needs. And they are beneficiaries of the long-term care insurance and facilities, and the rate was 6.1% in 2013 and 8.0% in 2017, and it rose to 9.3% with a total number of beneficiaries amounting to a very high number. So in terms of percentage, it doesn't seem so high, but in terms of numbers, the number has skyrocketed. And if you look at the long-term care facilities and staff, we have averagely 3.5 people for 100 older persons, which is quite less than the OECD average of 4.9. As for Denmark, they have 8.1 people, and Sweden, Norway, and they have an average number of 12.7 people for 100 older persons. So long-term care workers and staff is one another area that we need to consider in terms of their education and attribution. But another thing that we have to note here is that the ratio of part-time workers of LTC, long-term care staff, is very high. Japan has only around 17.5% of the part-time workers in long-term care staff composition, but our ratio goes very high compared to Japan. Our rate is around 60%. And as for the number of beds in residential LTC facilities, it has been decreasing, and Japan has decreased by 6 beds, but Korea showed an increase of around 30 beds. But what is notable here is that this light yellow and dark yellow Well, actually, dark yellow represents LTC facilities, and light yellow represents LTC hospitals for the elderly. So what's notable here is that we have more beds in LTC. 2/3 of beds exist in LTC hospitals, and 1/3 is assigned to LTC facilities. So we need to think of the right balance of the beds between LTC facilities and hospitals for the elderly. And we have seen the ratio of older persons living alone, which was 16% in 2000, and it got up to 19% now, 2019. So an increase of threefold. We would say that 1 in 5 older persons is living alone. Then how can we deliver education and information to these older persons? Well, if you look at the education system from infancy to the adolescent period, and we start from primary to tertiary education through secondary. And as for the elderly, they also have different levels of care facilities. And as for children, well, the centers focus on child care, and these child care can be likened to residential nursing homes. And just as kindergartens provide basic education, and it can also be compared to adult daycare centers, which mostly assist transportation as well. So at specific ages, if we can consider that going to a certain specific facility is natural and well accepted widely in society, it would also be appreciated because the older persons show a hesitant tendency to go to those kind of facilities. Well, it is said that we have around 60,000 community centers for the elderly nationwide. And if you compare this to Japan, and Japan has a active operation of these type of senior centers in each region, and it is said that Japan has benchmarked our the elderly care centers and activity centers. Well, culture center for the elderly has been widely used in cities, and the silver programs can also be efficiently operated by local governments and the center government, and you can also benchmark some clubs at universities, at schools for the elderly, and who can do what. Firstly, I would like to point out this. Medical doctors for older person, and especially registered medical doctors for older persons. For the vulnerable, we talk about attorneys and lawyers who can help them. Then who could represent older persons? Medical doctors, I would say, and this is a critical question given to us. Then when registering a medical doctor for older persons, you may say that if you could assign medical doctors for all older persons, it would be the best option, and other people in our country as well. Yes, it's true, but what I recommend is to start for older persons. Well, we say that the age 70 is the reference age to categorize an older person. 70 for Korean male and 75 for females, and it is reported as life expectancy in 2016. So my proposal is to register medical doctors for older persons aged 70. So if we could register that system for the older people, then the drug prescription can also be well managed. And as for community care center and elderly care centers, well, the basic concept of community care is to accommodate older persons at their own places, but sometimes it is harder for community care center staffs because the older persons cannot stay by themselves at their places. So it is more safe depending on the physical conditions of the patients to use resources of local community. So as mentioned earlier, to evaluate and diagnose the physical conditions of older persons, the role of elderly care centers and the registered medical doctors is quite important. And there are visiting centers, visiting diagnosis system, and full-time care coordinators. And these are some benchmarking cases of Japan's system, and we have to complement these areas as well. Then who will be in charge of care plans for older persons? Well, it is also feasible for us to recruit new staff members nationwide, but I would suggest that in expanding the role and responsibilities of existing staff will be more practical. In terms of the care plans under the long-term care, they can also play a role of coordinator between visiting diagnose experts or home care nurses and key hospitals, elderly support centers or primary care centers. And these primary care managers can, in terms of primary care coordinators and staff members, and they are 100% hired by private hospitals. So if from the perspective of local government and central government, if they can recruit a coordinator who can do a bridging role between patients and those care staff members of hospitals, and it will be util for all of them. And we also have to reorganize the national health screening. As for older persons aged 85 and over, the cancer screening can be customized to their physical conditions. Well, there's national health screening system, but in case of the health screening for cancer, the criteria of the age is set separately. So that is why I am suggesting the customization of health checkups. And lastly, older persons are in the dead spots of healthcare. So there are attorneys for the socially vulnerable. I would like to suggest medical doctors for the elderly for their health rights. And if doctors can play a crucial role between older persons and health institutions, and will be making great contribution to older persons and older persons to be. Thank you. Thank you very much for your presentation. So we were able to see the aging trend of not only Korea but of the world, and we also are noted of how to promote and secure the rights to health of the elderly. It has given us many implications. The speaker also suggested a medical doctor for older persons while suggesting the direction for community care. I am sure that there should be many questions from the floor and from the YouTube chat room considering this subject. And thank you very much for opening up this session with wonderful presentation, Dr. Lee. And moving on.
Now we will hear from Ms. Nina Monrad Bull, health counselor at the Embassy of Denmark in Korea. Health Counselor Bull facilitates cooperation in the field of healthcare between Korea and Denmark. She graduated from the University of Copenhagen. She has a Master's of Science in Medicine and Bachelor of Science in Political Science. And she also studied in University de Rennes and Paris Sorbonne in economics and political science. Harvard University as well as Oxford University. As I mentioned, she acts as a facilitator between Korea and Denmark in healthcare. The floor is yours.
Thank you very much. And thank you very much for inviting me today. Thank you to everyone who's been working very hard to organize this important conference. I also want to say especially thank you to Chairman Lim for your collaboration with the embassy. And thank you, Dr. Lee, for your presentation and for highlighting the demographic changes and the implications of human rights of the elderly citizens. So I will speak about the Danish case and about the healthcare system in relation to the elderly during COVID-19. First of all, for those of you who are not familiar with Denmark, we are a quite small country in the northern part of Europe. We have approximately half of the square meters of Korea, and we have a tenth of the population of Korea. If you look at the demographics of our country, you will see that, like Korea, we have an aging population. People are living longer and getting older, which poses certain challenges in relation to our healthcare system, and of course also in relation to COVID-19. Elderly people in Denmark, for the most part, experience a high degree of social security via the Danish pension system. The local municipality provides home care services in accordance with the needs of the individuals. The state provides health care and rehabilitation free at the point of delivery, which is paid through our taxes, as well as subsidies for medicines. Most elderly people in Denmark, defined by the age of 65 and above, live in their own homes. So on average, it's actually only about 3.6% of Danes above the age of 65 who live in nursing homes. The average age of people moving into nursing homes are 84 years. And people live on average 2 years and 8 months before passing away in a nursing home. And this is not a sign of bad care in the nursing home, but it is rather the fact that only the most frail elderly are considered eligible for a spot at a nursing home. Given that the elderly tend to fall more ill more often than the young, it seems relevant to provide you a brief overview of the Danish healthcare system. The Danish healthcare system is most exclusively funded through taxes. As such, due to this, it's free at the point of delivery for the users. Hospitals are run by regional entities which all work together in the Danish regions. And the general practitioner is the first point of contact in the Danish healthcare system. It isn't possible to access specialized treatments without the referral from your GP, your general practitioner or family doctor. And that is, of course, except for emergency care and other things that are, there are certain exemptions to that. But it's also worth mentioning in regards of healthcare data, it's possible to share an individual's healthcare data between different entities in the healthcare system. And this is to facilitate a higher accuracy and continuity of the treatment. In Denmark, almost every citizen is connected to a general practitioner, a local GP, a specific family doctor, and that is where people go to when they're feeling unwell. On average, a GP has 1,600 patients connected to their practice, and GPs deliver about 30 million contacts a year. 30% of these are phone consultations, while 70% are face-to-face consultations and home visits. It's possible to change doctors, but usually people find someone who live close by and who they feel comfortable with, and then they stick to that doctor. Usually a person will have the same GP for long periods of time, and it can potentially be their whole lifetime. So often the GPs will have entire families connected to their practice. And all this gives the Danish GP a unique understanding of their patients and of their backgrounds. So this means that a GP can, for example, be following a mother closely during her pregnancy, follow the child within the checkups during childhood, handle chronic diseases in relations to the grandparents, and etc. So they have this full picture of the family. And these GPs are specialized in handling many different conditions and knowing when to refer. So being the first point of contact in most encounters with the healthcare system, the GPs have the role of gatekeepers to the rest of the healthcare system. Thus, it's only if they deem that whatever a person is suffering from is severe or serious enough that he or she can get referred to specialized diagnostics and treatments. And in this way, the GP are also a very important factor in regulating expenses in the healthcare system overall. About 4% of patients are referred to hospitals, 2% to community specialist care, and 2 to 3% to auxiliary services, and that is, for example, physiotherapy. GPs, they also carry out a range of treatments in their clinic, and they also can prescribe medicines and control a lot, several chronic diseases and have follow-up. So GPs, they have this very special and important position as the link between secondary and tertiary care, meaning the specialized care received in hospitals, and then the primary care, for example, also rehabilitation provided by the municipalities, and all this in the course of the treatment for the patient. In line with this, it's often the GPs who are responsible for doing follow-ups with patients after being admitted to hospital to make sure that everything is as it should be, checking that prescribed medication is working, etc. So in relation to the elderly who often have a high comorbidity and fall ill more frequently, this is particularly important as they can have often have many more contacts with different parts of the healthcare sector with different specialized doctors. So the general practitioner has this overview of the person's entire medical history and current treatments, and this is very important for coordination and for further treatment and follow-up in different aspects of the treatment course. So in this way, the GP system helps ensure continuity of care, which is an important aspect of maintaining the dignity in the care of the elderly. Meaning having a clear and well-coordinated system for their healthcare, instead of having them seen by many different doctors without really having a understanding and coordination of the sometimes complex situation of the elderly. And one aspect which also Dr. Lee was touching upon, the polypharmacy, so also having someone who's following up specifically on this for the elderly. As for COVID-19, first of all, no patients have been brought into financial trouble due to the treatment of COVID-19 because we have everything is tax funded and there's no co-payment for the patients and no outlays. Because Danish hospitals have a common coordination entity in the Danish regions, it's been possible to transfer doctors and equipment between different parts of the country, depending on where the caseload has been the highest. The GPs, as the first point of contact in the healthcare system, has been responsible for communicating and advising people who had symptoms of COVID but haven't been tested yet, and to be able to advise them by phone. And they have also been sparing the hospital from the burden of the mild cases and having the hospitals focus their resources on the confirmed and on the severe cases. Furthermore, the easy sharing of individuals' health data between different entities have meant that all information relevant to the treatment of a COVID patient has been available when needed. Further, we've increased our test capacity rapidly over the summer, and currently we have completed about 8 million COVID-19 tests. And in order to make sure that people actually got tested when needed, we've made it possible for citizens to book a COVID test directly online without a referral from the GP. And all of this, of course, free of charge. Now this is for the role of the healthcare system. However, the Danish government has also played a significant role in the response to COVID-19. Due to a sudden increase in the spread of COVID-19 in February, the Danish government decided to have a lockdown of the country, meaning that all workers but essential staff were sent home, cultural institutions and entertainment venues were closed, cafes and restaurants were closed for customers, only takeaway allowed, and all stores were closed except for example, pharmacies and grocery stores. People were advised to stay home and not see friends, no family. Especially the elderly people living at home were considered of a greater risk of dying with COVID-19 due to their age, so they were advised to stay home and not to meet with anyone. Furthermore, during the spring, we had a complete lockdown of nursing homes. Home care services significantly were reduced, and it was not possible to visit people in hospitals. Regular care and treatment at hospitals were postponed as far as possible. So there has been some, not a lot, but there's been some critique of the government's handling of the elderly during COVID-19. First, it could be seen as a sign of age discrimination when all elderly people in Denmark were lumped into the same high-risk group, instead of taking into consideration the diversity in health and in abilities amongst the elderly. So there's a big difference between being 65 and 90 years of age and having different chronic diseases. And this could argue for more differentiated guidelines depending on specific age and comorbidity. So secondly, we know that the elderly have an increased risk of dying, but as some are old and have relatively short time left, and as we don't know how long time we will have COVID-19 with us, we should also consider their quality of life. So we have to consider what is most important, adding life to years, or adding years to life or life to years. And this is, of course, an important question for the healthcare system. But I think that COVID-19 has given a certain edge to this question. We have no scientifically collected data on the experience in nursing homes. However, many places reported that the elderly felt lonely and needed stimulation. In response to this, the Danish Health Authority, in collaboration with the Danish Knowledge Hub for Dignity in Elder Care, made a collection of ideas for COVID-19 safe ways of stimulating the elderly living at nursing homes and at home. Examples of ideas included in the publication are ideas for activities done together in smaller groups, ideas for indoor activities done together at a safe distance, ways to support ways to stay in contact with loved ones during the crisis, and special support for elderly living at home, including guides on home exercises. But how did the elderly actually cope with the lockdown and COVID-19? One recent study from Denmark called Standing Together at a Distance, documenting changes in mental health indicators in Denmark during the COVID-19 pandemic from the University of Copenhagen showed the following. First of all, it showed, despite being at a significantly higher risk in relation to COVID-19, the elderly didn't worry significantly more than the young. Secondly, it showed that the elderly actually rated slightly lower on social isolation during the lockdown in the spring than did the younger generations. Third, on average, the elderly, however, only in the age group of 65 to 85, reported feel that they felt less lonely than the younger people. This was 5.7% in the elderly and 8.7% of the general population. Fourth, the study showed that elderly people living at home showed good coping and mental resilience using their networks and the opportunities of technologies available to them. And lastly, this study showed that a low degree of financial insecurity among the elderly because of the Danish pension system. So there were more worries for the young who were at risk of losing their job and main source of income. So it should be noted that the experience of the lockdown in nursing homes has probably been quite different, as nursing homes were completely closed down, unlike the elderly living at home who were advised to self-isolate but didn't strictly have to do so. However, we don't have any scientifically collected data on this. And these slides were, as you can see, submitted in November. So I will just give you the current numbers of COVID-19 in Denmark as of yesterday. So as I mentioned, we have now completed about 8 million tests, COVID-19 tests. And there has been a total of 92,649 cases since March, and a total of 5,530 COVID-19 hospitalization cases since March. The number currently, as of yesterday, was 328 COVID-19 patients in hospital. And the death rate has decreased slightly, so it's now 1.0%. If we look at how COVID-19 cases are divided between age groups, we see that the elderly have been really good at not falling ill. Despite accounting for approximately 26% of the Danish population, the elderly from age 60 and up only make up about 15.7% of all COVID-19 cases. Based on the low case rate amongst the elderly, combined with the overall, at least as far as we know, relatively positive experience of being in lockdown in Denmark in the age of COVID-19, I think it's fair to say that Denmark has done fairly well. And with this, I will end my talk. Thank you very much for listening, and please send any questions and be in contact. Thank you.
예, 대단히 감사합니다.
Yes, thank you very much for the presentation, Dr. Nina.
아주 자세하고도
Thank you for the very detailed and for the most recent data
26%나 되는
on Danish. So you talked about the 26% of the elderly population in Denmark, and you talked about what was going on in terms of healthcare system for the older persons.
되게 하는 이런 1차 의료
And you also talked about the role of the primary health care to deliver better care for the older persons. And actually, GPs coordinate between different agents and share information for the elderly, as the senior citizens tend to suffer from comorbidities.
인권을 보장하는
And you also
요소가
talked about some of the elements that are critical to ensure the human rights and the right to health for the senior citizens. You also referred to many studies
권리에 따른 외로움 등을 어떻게
to highlight on how the older persons were feeling amidst the COVID-19 in terms of isolation and their loneliness.
다시 한번 감사를 드립니다.
So thank you very much, Dr. Nina, for the presentation.
지금부터는 이제 패널
Well then,
토론으로
let's
진행을 하겠습니다.
go on to panel discussion.
분들은 이 의료계에서 두 분,
And we have
이 분야에서 두
two from medical sector and two others from social welfare sector.
드렸습니다만은
Well, as introduced earlier in the beginning,
장승남 교수님,
Professor Chang Yong-ho, Professor Jang Sung-nam, and Professor Im Jong-han and Researcher Kim Jong-nan
하도록 하겠습니다.
will make their comments
첫 번째
in their order.
전용호
And
교수님을
first,
소개해드리겠습니다.
let me introduce Professor Chang Yong-ho, the first panelist.
해주시면 감사하겠습니다.
Maximum 10 minutes is assigned to each panelist.
사회복지학과 부교수로 재직 중이시고요.
Associate Professor Chun Yong-ho is from Department of Social Welfare of International University. He graduated from the Department of Sociology at Yonsei University and earned a master's degree and a doctor's degree in social policy at University of York in UK. And he is now working as expert member of the Community Care Committee of Social Security Committee and also deputy chair of the Korean Gerontological Society. And he is the chair of Academic Committee of the Korean Academy of Long-Term Care. Please. Nice to meet you all. As introduced, I am Chun Yong-ho from the Department of Social Welfare of International University, and thank you for inviting me. And through two presentations, I have come to know about many different issues of health rights of older persons in Korea. And Korea also should establish many supporting and responsive systems for those issues. And those two presentations are quite insightful. Long-term care insurance and primary health care system have been touched upon a lot. As the first speaker has well highlighted that one of the crucial challenge for older persons is to expand the practical healthy life expectancy. Just making life expectancy longer is not an issue, but healthy life expectancy matters for older persons. And to that end, chronic diseases should be well managed for the elderly, and that's the key point of long-term care of Korea. So the long-term care should be centered more on older persons in each local communities. And in that context, Denmark has shown some practical cases like GP for people in local communities by providing a comprehensive medical services, and depending on circumstance, if there's any need for or a desire for further medical services, a referral and a coordination system are in place, and that was quite helpful to know. And GP can also provide some medical consultation over the phone, and this is something that I haven't been aware of. So considering that, we, Korea, does not have that kind of GP system, but the system is not implemented from the perspective of users, and that is more centered on supplier perspectives. So for users to get, for users to use the medical service in a more convenient way, we do not have a GP system that supports that kind of approach, and public system is quite unsafe unstable and weak. So supply-centered system is in continuation. That's what I assume. I totally agree with the idea of Professor Lee, the first speaker, that the GP system in region should be led by local governments so that the local residents can lead their healthy lives at their own places. And community care, for example, whose core element is to have a registered GP or medical doctor for older persons, and that should be rooted deeply in the local medical care system. And the long-term care insurance, how can we manage this in a long-term perspective? Well, as we all know, the staff members of the NHIS is focusing on categorizing or making classes and monitoring services, and depending on the changes of needs for medical services, there should be appropriate modifications, but due to the lack of care manager system, after being graded, supportive procedures are not in place. And recently, the support for usage system has been implemented, but it's not still sufficient for covering all needs in the field, and the voluntary care staffs are not included into a care system. So as a part of long-term care insurance, visiting medical service is partially included. So long-term care service is not enough to deal comprehensively with older persons. So NHIS staff members should do part of these caregiver duties, like UK. They have a gatekeeper system to do a coordination role. And if you look at Japan, their care management system is based on private sector. So over-provision of service is sometimes claimed to be unnecessary, and that's one of the issues. So considering all these pros and cons, care management system should be adopted in Korea, and officially and unofficially, welfare and medical services should be included in a care management system. And we also have to think about a breaching system by the government. But in 2016, the deficit of long-term care insurance has been reported. The primary medical service and the innovation of long-term care insurance, these two pillars should be the priorities to solve. And regarding COVID-19, I was lucky to listen to many different cases of Denmark. As you all know, COVID-19 has been prolonged, and even with the arrival of vaccine, well, usually it takes at least 5 years to 10 years for a specific vaccine to be approved, but it got an emergency approval for this case. So all of us are doubtful of its effect. Will the effect last for 2 months or 3 months? And everything is uncertain here. So the prolongation of COVID-19 should be well managed by us, and long-term care is not enough to handle not only older persons but also the disabled, because face-to-face medical service is not appropriately provided due to COVID-19 situation, and many challenges are observed in the field. So in a contact-free area, yes, substitute services should be developed. I claim an AI doll robots like Hyodori and Hyosuni. I have an experience of having interviewed some older persons, and I found out that those older persons are happy to have a communication even with the doll robots, because they are not having many chances to communicate with real people. But through that kind of mimic communication with dolls and robots, and their depression tends to be getting relieved. So that's what I found from that survey. So contact-free area should be expanded in an aggressive way. Also, in the sector of welfare, usually social network is decreasing for older persons and their social role is declining as well. So they have least chances to have contact with people, and resulting from that, many challenges are observed. So contact-free areas should be developed and enhanced for older persons. But we cannot only be dependent on contact-free activities for older persons. But if you look at the current welfare systems from the point of view of older persons, it seems that we are too much conservative and you're too much sensitive. Of course, I understand that we need to be cautious about COVID-19, but if we could do group activities like walking around the village with all older persons, with all residents with masks on, that could also be helpful for older persons. If we focus on not providing contact services for older persons, and that will aggravate depressions and the physical functions of older persons. And that's why essential contact services should be provided. For my worries, of course, being pursuant to quarantine guidelines. Well, overall, due to COVID-19, we come to recognize once again the role of a nation and the importance of welfare and national health care systems. And we need to complement the system with the perspective of users so that we can innovate a long-term care insurance system and the activation of contact-free activities and support and maintaining essential contact services with sophistication. Thank you.
예, 대단히 감사합니다. 아마
Thank you very much.
앞에 발표해 주신 두
Well, in times of COVID-19, he made his comments on the same page as two previous presentations, and he has highlighted the importance of rights to health and solutions to guarantee human rights of older persons in this era. Thank you.
Next, we will hear from Professor 장숙랑.
교수님은 서울대학교 간호학과를 졸업하셨습니다.
She graduated from Seoul National University College of Nursing. She also have MPH and PhD from the same school. And she also did her postdoc as a research fellow at Harvard School of Public Health. And she is also an expert committee member of the Committee of Social Security under the Ministry of Health and Social Welfare in South Korea, as well as for the Visiting Community Center program at Seoul Metropolitan City Government. She is also the editorial board member of the Asian Nursing Research and the Korean Society for Nursing. The floor is yours. Good morning. My name is 장숙랑, as introduced. So we need to have policies for healthy aging, and that can achieve equality, especially when it comes to women, low-income people, as well as those with chronic illness, as well as comorbidity. We need to pay more attention for those older persons. That was the impression that I got from the two presentations. Of course, we need to, as I said, we need to aim for equal healthy aging. So it has to be equal, but at the same time, we need to aim for healthy aging of the older persons. It is in this context that the Seoul City needs to come up with a master plan for the healthy aging of the older persons. And of course, respect for the older persons must be the core value in devising the master plan, especially especially in the age of COVID-19, we need to look into the health and human rights of the older persons, and it was a great opportunity to do so. In particular, we see a lot of infections in nursing homes, as well as the different residential care facilities and care institutions. And that led to many deaths, but the older persons were not at fault, and they were just infected by the virus that came in from the outside. And in that sense, they were the vulnerable class. So we have to look into the contagion between institutions as well as within institutions. And is our infection management system working? We have to ask such a question. And that actually led to the question of human rights for the senior citizens, especially the abuse as well as the neglect of older persons in institutions have also emerged as a social issue in Korea. So we can't just confine the older persons in those institutions, and that is not the solution. We have to come up with a better solution to improve their quality of life. So we need to reflect on them, especially when it comes to home care service. They have to stay home because of the social distancing and quarantine measures, and because of that, they are becoming more frail than ever. And at the same time, they're losing their muscle strength and suffering from other types of problems. So we have to come with guidelines as well as programs at the government and the municipal level to make sure that we promote the human rights of the older persons. Especially, we have many older persons staying at home alone, and they have now limited access to nutrition. So when they go out and have meals, they do not just access nutrition, but we say that they access relationship, because even when they exercise, we see so many research results that indicate that senior citizens tend to become healthier when they go out and interact with other people. So that is why we have to look into the topics of nutrition access as well as isolation. And at the same time, now we see a lot of delay and collapse of our health system. Especially when patients are treated with acute phase, and then they are transferred to nursing homes. But then at the nursing homes, they say you have to get tested for COVID-19, and then hospitals just send the older persons around, so they have to bounce back and forth between different institutions. So we see this collapse of the health system when caring for the older persons, which we need to address. So we had those problems even before the outbreak of the virus. However, we are seeing problems being more pronounced with the disease, the pandemic. At the same time, the caring services have been suspended and have been reduced. So we experienced those problems even before the pandemic, but now it's even more serious. And we are seeing many reports that say that we see less and less caregiving for the older persons. At the same time, we need to also promote the health literacy of the older persons, so that we provide equal access to health information to the different populations. So I was impressed by some of the cases in Denmark, especially there was this research that looked into the older persons, but they are not in the workforce, and because of that, their mental health was less affected than the youth.
공공근로가 중단됐기 때문에
And now, because the public working sector has been suspended, the older persons working in such a sector in Korea are hit the hardest in Korea. So we were able to see this comparison. At the same time, the basic pension for the senior citizens has increased recently when it was adopted in 2014. And from 2015, we saw a decline of the suicide rate of the older persons. So we have to really take these older persons into account when we come up with policies so that we can actually address the health problems of the older persons. And we also heard about the GP system and the data sharing between the public hospitals and the health data sharing between the hospitals in Denmark. So that was quite impressive. I think that our national health insurance institution can actually play such a role in Korea. So it's not just about protecting the privacy, it's really about enhancing the quality of life and promoting the human rights of the senior citizens. We now live in the age of COVID-19. We have to make sure that we address the caring gap caused by the COVID-19, and all the different stakeholders and all the different generations have to come up to forge solidarity and work together. And I think that local government have a greater role to play. So let's have a master plan for the health of the senior citizens to promote their human rights. Yes, thank you very much. You talked about equal health aging. I think that was the topic that you wanted to raise with your comment. So we need to secure equal and healthy aging of the older persons. And you proposed different ideas in terms of policy as well. I think we will receive many questions during the Q&A session. Thank you very much for that.
And next is the third analyst, Professor Im Jong-han. He's graduated from the Medical School of Yonsei University and earned the PhD of the Occupational and Environmental Medicine at the same university. And he is currently chairman of Korean Academy of Primary Health Care and also former chairman of the Korean Solidarity for Social Economy and Community Care Health Medical Consultation Association, and he is the president of Korea Health Welfare Social Cooperative Association. Please, now the floor is yours.
두 분의 발표를 통해서
Well, through two
현실상이
presentations,
라는 것들을 진단하고
we were able to diagnose the current situation of Korea and also to know the future direction for the healthcare system of our country. They were quite valuable in that sense. We are living COVID-19 era, which is unprecedented, but globally it has left and it has been leaving a greater impact on the whole world, raising awareness about undiscovered challenges and issues of health and medical care system. And the current medical care system and the social care system don't seem to work properly for now. Through COVID-19, Korea has a well-established quarantine system and somewhat has been making success in responding to COVID-19. But the spread of COVID-19 is still ongoing, and the success of the initial quarantine is
있는 고령층한테
Now moving towards
확장되었으면
the greater spread out to older persons, and once it happens, we will not be able to control the number of confirmed cases, and many people would not get a chance to be treated, which would be quite unfortunate. In Korea, public health system is quite weak and unstable, and this will make our society exposed to another similar infectious disease and chronic diseases, and that will result in severe social crisis. The previous system was not working properly, but that could give us new opportunities. That's what I claim. So through two previous presentations, I was able to diagnose once again what were the problems of previous and existing systems and how older persons can live their healthy and vivid lives. We should find out a solution to that end. Well, the cases of Denmark were quite impressive to us.
기존에 있는 여러 시스템 부분들이 유기적인
existing systems are quite
있지 못하는 거에 비해서
organically
덴마크 같은 경우에서는
combined one another, unlike Korea.
어떻게 효율적으로 작동하는가
An efficient operational system seems to be well implemented in the society, like income guarantee and health insurance are organically connected to one another, as they could play two main pillars for a happy older life, like a GP system, and not only GP himself, him or herself, but nurses and other staff members and managers are quite well coordinated to one another, and that organic system is something that we have to take note. Korea has many infrastructures in place but not working properly, so these infrastructures are fragmented and not organically combined, and that's why we're seeing operational challenges. So in case of Denmark, the role of GP, well, the speaker said that the GP represents around 15% of total doctors, around 30,000 people. So we have approximately 100K doctors. So if we could run an efficient system, then we cannot say that infrastructure lacks in Korea. GP system is quite useful, and we will be using around 8% of the total budget for medical industry for GP system. So what matters to us is not the lack of infrastructure or resources, but the inefficient usage of existing infrastructures and resources. We were not organic enough, so re-infrastructure and recalibrating is necessary. GPU and the nurses of communities or local nurses, they should be combined, they should be coordinated. The importance of GP has been highlighted very well by Ms. Nina Bowell, health counselor. The key is to have organic teams of GP and local community nurses who know how to organically use local resources for local residents at appropriate time. And that system should be started from people, GP. So that's the key part that we need to benchmark from Denmark. And I hope that we could make changes gradually from that point.
서울시가 그런 변화를 만들어가는
And
데서
I
중요한
personally think
역할을
that
했으면 좋겠다는
SMG, Seoul
부분입니다.
Metropolitan Government,
그러니까
should play a key role in that
일일
process.
교육감에 전체적으로 개입하지는 못하지만
So,
지금에 있는
Metropolitan Government cannot engage in the whole process of educating and training medical staff, but there are some hidden places, hidden stages that they can be engaged in. We can make nurses play a role in local communities, and Seoul City is now working on this test project. But it seems to me that this project can only cover the taking out some benchmark cases. So doctors should lay a foundation to form a proper environment. Innovative measures should be in place to connect local nurses to doctors and to support practices of GP on spot, like education, training, and establishing a network so that the structural issues could turn into sustainable ones.
가능하지 않을까 이렇게 생각되었습니다. 제가 2019년도에 사실 서울시에
2019 that I suggested a GP for older persons.
코로나19 오기 전 상황에서 제안을 드렸고
before COVID-19,
앞으로도 올 수 있는 보건의료 상에서 굉장히 중요한 역할을 할 것이다 이렇게 제안을
will
드렸는데
play a role for coming crisis of public health, and that's what I suggested last year. And it is now high time to review that proposal because being proactive and having preliminary investment in public health is quite necessary now. And we are supposed to lay a foundation from now on.
서울시가 이 엉켜진 부분들을 나름대로 풀어갈 수 있는
Entangled knots
있다고 생각되기
should be
때문에
untied from that point.
엄중한 시기 속에서
Under the serious times of COVID-19, we are going through a crisis, but we need to objectively diagnose the situation, and public health system should be organic
통합성을 갖고 있는 시스템을
and should be integrated in an organic way, and that should be led by Seoul Metropolitan Government to respond proactively to aging and public health of older persons. Thank you very much. For GP system and the Korean medical service provision system. And concerning these subject matters, he has just given us remodeling and restructuring agenda. He's been claiming this for a while, and he has been quite consistent in that sense. And in particular, GP system for older persons should be initiated by Seoul Metropolitan Government. That is also the proposal of this panelist. Thank you very much. And lastly,
now moving on to the last panelist of this session. She is a research fellow at Seoul Welfare Foundation. We will hear from Dr. Kim Jung-hyun. Dr. Kim received a Doctor of Philosophy in Social Work at the University of Georgia, and she is currently Research Fellow at Seoul Welfare Foundation and was Associate Research Fellow at Korea Institute for Health and Social Affairs. The floor is yours. Yes, good morning. My name is Kim Jung-hyun, as introduced. Thank you very much for the presentations and the comments.
저를 이 자리에 초대를 해주신 거는
So I think the organizer invited me to speak here to talk about the human rights of the senior citizens and the right to health of the older persons from the Seoul Metropolitan government's perspective. And I'm sure that you want to hear more about how we plan to respond to the challenges to come. So
들으면서 생각했던 이슈들에 대해서 좀
I would like to also briefly talk about some of the questions that I have listening to the presentations. So because of the social distancing, the vulnerable are suffering a great deal. Even before COVID-19, they suffered from lack of social resources, but now they have little access to regional resources as well as welfare access resources. And when it comes to the population over 65 years old, they are classified as high-risk population, and they are more exposed to social risks. And as Professor Lee mentioned, regardless of their income, people over 65 years old have little access to information. And as we engage in social distancing, they fall under high-risk population. So given that we have moved into contentless lifestyle, I believe that human rights as well as right to health for the senior citizens and older persons is quite timely. So I would like to talk about some of the agenda that we have in initiatives that we do at Seoul Metropolitan City to ensure a quality of life for the senior citizens. So usually when we talk about human rights for the older persons, we talk about abuse as an opposite terminology. And actually 13.3 out of 10,000 persons over 65 years old suffer from abuse. And in accordance to our ordinance, we conduct a survey on the older persons, especially. We surveyed 3,000 persons this year with a focus on abuse. And their level of awareness went up. 11.9% said that they experienced abuse, which included emotional abuse as well as verbal attack and shouting. And now the senior citizens are aware that the emotional abuse is abuse as well. And they are not included in the decision-making process, and they understand that that's a part of the abuse. So, and 0.9% suffered from physical abuse and neglect. And of course, this was conducted on the persons over 65 years old with sound cognitive ability. However, we can see the picture. And as we enforce social distancing, then their anxiety will increase when it comes to us being isolated. And now we are receiving more calls to our center in terms of abuse. So we have this 2020 Senior Citizens Master Plan that the Seoul City planned. And this is a master plan that we want to provide to ensure the welfare of the older persons in the mid and long term. So we are now looking into the factors that we need to address or improve. For instance, to improve their access to information as well as to provide the channels to make calls via online channels. And we are also carrying out different campaigns. So we have Plus Smart Care. And as Professor Chun mentioned, we are linking to AI and IoT to provide services for the older persons. So our topic, one of the main agenda is smart care. For instance, we want to make sure that older persons now are aware that smart care is part of their life. So, for instance, we have this sensor that we attached to the diapers for the senior citizens, and whenever they make a mistake or so, then their caregiver will be notified and be able to provide care to the person. So this was a result of the feedback that we received from the older persons with respect to the quality of life that they want to enjoy. So, and as a result, they were able to enjoy a better emotional stability, and caregivers were also able to enjoy better satisfaction. So how are we going to embed the technology in providing care for the senior citizens? So those are some of the initiatives that we have come up with, and we want to really spread those technologies and apply that to a wider scope. And as I mentioned, we have this wider this master plan that we have come up with, and we want to increase the scope of application. And of course, it is very important that we also certify it so that people are aware of the quality of the service that we provide. At the same time, we also have regulations to protect the human rights of the older persons, and we provide training. And as Professor Tang mentioned, she talked about the importance to access to nutrition as well as food. And one of the ideas that we provided at Seoul Metropolitan City is access to the food and nutrition. And that is one of the core pillars when we provide welfare for the senior citizens. And I conducted my own research on that. And of course, food and housing and etc. are some of the essential services that the older persons should access to. But then now, as of 2019, we actually started to provide customized delivery of meals to 135 older persons. This was a pilot test, and we did that for 6 months. And the outcome was actually better than what we had expected. So their physical abilities increased, and we saw significant outcome as a result. And their depression level also declined. At the same time, I said that we also have this caring certification system, which is part of the long-term caring system for the older persons. And for instance, we wanted to reinforce the framework for that. So of course, we did have some plans for the children and meals for the children, but we did not focus so much on the older persons. But what we want to have is we now have a plan to provide long-term care for the older persons in terms of food delivery as well as nutrition care and their meal delivery and hygiene management. And we have laid out some indicators for that, and we want to apply that starting from next year. And so I talked about some of the initiatives that Seoul City is planning to provide to the older persons. And as I listened to the presenters, this was the impression that I got. Well, the GP as well as the GP system and the social welfare system, you know, as I'm a major of the social work, I do feel the need for that. But then when it comes to the caring centers for the older persons as well as the using and mobilizing the regional resources for that, well, some of the presenters talked about the need for that. But who will take the initiative? Will the central government lead the initiative, or will the local governments lead the initiative, or will the health organization leads such an initiative. So we have to make sure to really divide the roles and responsibilities when implementing such policies. So I think we need to discuss more on that. Thank you very much. Yes, thank you very much for that feedback. So you talked a lot about what Seoul has provided as initiatives, and I think that you also raised a question for discussion that was a big topic that I think you wanted us to discuss, and I think we will have many questions for that. So we've heard 2 presentations and 4 discussions from 4 panelists. So we are not seeing any questions on the YouTube channel. So let's do it this way. So first of all, let us maybe give the floor to the 2 presenters. If you want to add any comment to what the panelists just said, please do so, and then we can have a Q&A session after that. And later on, if you have some suggestions for the city of Seoul, then let's hear those suggestions and feedback before wrapping up.
We have around 10 minutes to go. So please keep your comments concise. Then Professor Lee and Councillor Nina, if you have any further comments to add, please. Mr. Lee?
두세 가지 말씀드리겠습니다. 하나는
Well, I have 2 to 3 comments. First,
저희 노이주치
connection.
사실 현재 시스템에서는
Well, under the current system, when we have a dedicated GP for older person, and it is quite difficult and hard for GP to have a visit in person for the relative older person. So that's the role that should be given to nurse. Well, so what's important in a case of Denmark? Well, what matters to us is that we do not have a data sharing system at a care hospitals, not care facilities. So these days there are not many patients living with their family members, and that is why it is quite hard for us to get appropriate previous conditions information of the patient. So there should be someone who could deliver the previous condition history. That could be visiting nurse, that could be GP, but the visiting nurse should play a bigger role in here practically. And when we are not allowed for visits for the patients, then there should also be someone who's in charge of delivering the exact physical condition of the patients to outer people. And if you look at the model of Denmark, we were noted that the GP would also prescribe necessary drugs and medicines for the patient at the hospital. Well, if you want to register a GP for older persons, yes, I know that that should be complicated and there should be lots of stakeholders related, but I want this to get started simply like I suggested, that we can simply register a GP for an older person of 70 and over, and local governments like Seoul Metropolitan City can receive a registration process by giving an advantage to older persons or the GP. Then step by step we can fill up lacking parts. Well, that's what I thought. So symbolically, we could start from 70 or 65. Of course, we have to have further discussions on the starting age, but if you could simply register a GP for older persons of 70 and over, yes, I think it is a good idea. It should be a good idea. Well, concerning that, I would like to ask a question to Ms. Nina. How is it going in Denmark?
Could you more explain about the situation of your country?
Thank you very much for those remarks, and thank you very much to all the panelists for your very interesting perspectives and words. I wanted to comment just on the part of the GP for senior citizens, the GP for older persons. I think this is really an important and interesting discussion. So just to clarify that in Denmark we also do have specialized doctors, geriatrics, specialized doctors for senior citizens, but these are considered as part of, mainly as part of our secondary system and not as part of our primary healthcare system. So our GPs are as I mentioned, focused for the whole family, for the whole span of a lifetime, and are specialized at handling diseases at many different parts of your life. I find it also interesting that in Korea you actually have, from the NHIS side, I know that they have a geriatric hospital, so I think that's also a very interesting perspective here in Korea. For the GP, I think, as I mentioned, it's very important to have this function of a coordinating doctor who actually has the full overview of a patient's diseases and comorbidities. So I think that this coordinating role is very important in terms of especially our senior citizens. But it's also important for other aspects, for example, for mental illnesses and a range of other areas. I think they play an important role. And then lastly, I just wanted to mention that I'm being here in Korea since 2019. I'm extremely impressed by your healthcare system and also about the rapid development of Korea and how dynamic and hardworking your country is. So I'm sure that that you will find very good solutions in terms of your senior citizens as well, even during this COVID-19 pandemic.
예, 대단히 감사합니다.
Yes, thank you very much.
혹시 이제 우리 패널들께서 아까 조금 질문
Thank you.
주신 말씀을
And panelists
have
not asked many questions. That they were more comments. So please, if you have any further requests to speakers, please do so. And I have one question to Nina. From your presentation, amongst the COVID-19 confirmed cases, the number of people admitted to hospital was relatively low. It was around 4,000 people admitted to the hospital. Then what happened to the rest of confirmed cases, confirmed people? Were they staying at home or at other facilities? I am curious to know. Could you please give us more details on that part? This is an interpreter. Do you want me to repeat the question?
I'm sorry, there is a little bit of lag in the interpretation, but I have your question now, and thank you for that. We have handled mild cases in own home, so people have been asked to self-isolate, and they've only been admitted to hospitals in severe cases. So that's why we have a relatively small number who've been admitted to hospital compared to the large amount who have actually been infected.
오케이, 예, 대단히 감사합니다.
Thank you very much.
한국의 경우도 코로나
Well, in case of Korea, at the beginning of COVID-19, all confirmed that people got admitted to hospital, but with time passing by, due to the lacking number of beds, and depending on the severity of the disease, we operate community treatment centers, and also light cases are requested to stay at home, being isolated, and I would understand the same for Denmark. And our panelists, please. Yes, I have two questions to Dr. Nina. As you know well, in North European countries, in terms of community care centers, they highlight the importance of community care centers and services provided by local communities, and that's why you have a variety of infrastructures of local communities. And Denmark as well highlights the importance of home care service, where doctor, nurse, and social welfare worker provide different services one another. But that area is quite weak in Korea. Well, would you please share that kind of experiences and services? What kind of home care services are you providing in Denmark? That's the first question. And the second question is as follows. One of the important factors of community care centers is to give a leeway and accountabilities with budgets to local governments. So the referral of rights and budget to local governments is very important to run an appropriate community care centers. And in Denmark, from a long time ago, decentralization has been implemented to give more rights and leeways to local governments. In case of medical services and public health services for older persons in local communities, what kind of roles are played by local governments? That's the second question. Well, recently in Korea, through community centers, a home care service is being provided, but to that end, the Korean government should think of decentralization to refer rights and budgets to local government. So would you please share your benchmark cases? Thank you.
Thank you very much for that question. So for your first question on the community care and local services, as I mentioned, first of all, the GP plays a special role. So the GP has the complete overview, and the GP will be the doctor who assesses the needs of the citizens, and that is also in terms of needs for home care. And the GP is also the doctor that can move into the community and have the home visits, especially relevant for the senior citizens. Then we also have nurses playing important roles. So nurses will be taking care of home care for senior citizens where that is deemed necessary, and taking care of medicines for the senior citizens, the administration of that. And then we would also have possibilities of having, for example, food delivery to the senior citizens and home cleaning and other services done in the home. So that's why we have a high degree or a high level of senior citizens who are actually staying in their own home. And we see that gives people a lot of value. It gives them dignity and a lot of control over their own life. So we see that it's quite positive for elderly who are capable of it to stay in their own home. And in terms of local governments and in terms of budget, and I think that we see that that keeping people in their own home is, of course, cost effective, and that is also very positive. And especially as we see the demographic changes that we've discussed today, and we see an increased strain on our healthcare services, and we really need to prioritize our resources, that is where it becomes important to have this strong local service and home care service for our senior citizens. And in Denmark, it is the municipalities who play a strong role in this, and especially also in terms of rehabilitation services. And it is, of course, we also have we have 3 levels, I would say. Then there's the level of the regions we have 5 of them in Denmark, and they're also in charge of the primary sector in terms of the GP. I think also in terms of the GP, that is where we also see the cost effectiveness, because keeping patients away from hospital beds as much as possible is one of the ways that we can ensure that we have sustainability in our healthcare system. Because as you, of course, all know, that it's a lot more costly to have patients admitted to hospitals. So having that very high level of GPs handling cases outside the hospitals and outside the secondary sector, as I also mentioned before, we see that as something that's really important and cost effective in terms of our changing demographics. But of course, we always need to ensure that we have ensured the well-being and especially also the mental well-being of our senior citizens, so we deliver the best possible services for them.
예, 대단히 감사합니다.
Thank you very much for that answer. Time is almost up.
네, 많이 있었습니다. 그래서
In fact, I think we are behind schedule.
이 응답은 또 이
So
정도로 마무리를
I think
하다가
we can now wrap up the Q&A session.
분들 순서대로
So we'll give the floor to the
인권의
panelists.
보장을 위해서 이런 것들을 좀
So do you have any suggestions to the Seoul city in terms of human rights for the older persons? We will hear from you one by one. So first of all, Professor Tong. Yes, thank you very much. Well, Seoul city has been leading different initiatives in improving welfare, and I think that Seoul lead by example in terms of development. And of course, we need to promote the human rights of the older persons. But to be able to do so, we have to have a user-centric system to ensure a quality of life for the older persons. To be able to do so, the central government's role is not enough. We need to work together with the local governments, as they are the closest level to the citizens. And as many people said, now we see a lot of fragmented initiatives. And yes, I understand that the central government needs to lead such initiatives. But at the same time, we need to decentralize and empower the local governments. And we don't see much cooperation between those working in the health and welfare sectors within the Seoul city government. So to provide a user-centric service, I think we should promote the collaboration between those workers. Yes, thank you very much for that.
네, 코로나 시대에 필수 의료라고 하는 것들이 있었죠.
There are essential medical services in COVID-19 era, like negative pressure rooms, and the GP system, and transition medical service, and visiting medical service, and visiting nursing. And these are essential elements for the aging society. Without these elements, human rights for older persons cannot be guaranteed. In that sense, human rights rights
예방하거나 방임을 예방하는 정책의
are
스펙트럼이 아니라 보다 더
not
넘어서서
just part of preventing what should happen, but those are rather more for guaranteeing the dignity of older persons staying at their own places. And as said earlier during the discussion, the Seoul Metropolitan Government's master plan for the health of older persons should be implemented. Thank you.
짧게 말씀을 좀 드리겠습니다.
Yes, so I will be brief.
돌봄복지 분야에서
So in providing caring services, Seoul City has been leading by example. And well, right now it has community integrated caring system as well as I look forward to Seoul City to provide initiatives for the aging society and to ease inequality. And well, Seoul City has been carrying out different initiatives. However, we see fragmented initiatives all across the country. So we have different initiatives led by different communities. And there were two initiatives in which Seoul City did not participate. And I think that Seoul City needs to provide an integrated approach that brings together the different communities. So I look forward to the city of Seoul to provide such an integrated caring system, and I believe that the discussions today will lay the groundwork. Thank you very much.
다짐을 한 말씀.
Thank you. And Dr. Kim Jong-yeon, would you please make a comment?
좋은 의견들
Of your
잘
will.
서울시에 전달해서
Well, I will deliver your valuable opinions to Seoul City so that we can facilitate more fluent and streamlined care services.
작동하고 있는 것 같이
Well, thank you very much. What we felt being operated right,
코로나19라는
like systems and structures
한순간에 허물어지는
against the COVID-19, we saw them dismantled and destructed completely. But we have to bear
대면으로 전환식
risks that we can, and we also should transform contact-free into face-to-face. And we should guarantee diverse basic rights, including rights to health. And to that end, we should be equipped with appropriate capabilities and structure. Thank you very much.
네, 대단히 감사합니다. 2020 서울
Thank you.
인권 컨퍼런스 2일차였습니다.
2020 Seoul Human Rights Conference. We are now on the second day of it, and we have just finished the first theme session under the title of Human Rights and Health of the Elderly in the Age of Health Crisis. We tried to diagnose the current circumstances, challenges, and seek out solutions. Well, with the aging society phenomenon, I also recognize the necessity to expedite the solutions to address this issue. Would like to thank once again all speakers and panelists and moderator, and also participants via YouTube. And would like to ask for your interest until the end of this conference. Let me make an house announcement of our event. Well, please take a picture of yourself watching this conference online and upload it to your personal SNS account with hashtag, and we will select some of you to give 100 coffee coupons respectively. And we will have around a 1 hour break and resume the theme session number 2 at 1 o'clock in the afternoon. Thank you.
Music always embraces an era. It holds the time, space, and scenery of the city that we love.
Is is a truly special city. This trail is an old railroad track that instead of being torn down, was completely reformed. The city has created a sense of ease and romance I had forgotten, and it surprises me every time I experience it.
You see? What another perfect reason to stay.
I moved to Seoul and now live and work here. I was very impressed with this culture that maintains original aspects while adding a new sense.
It's because empathy is what matters. People-centered values that prioritize the happiness of everyone are found across Seoul, where past traditions and the present coexist.
That warm feeling. Isn't that a great reason to live in Seoul?
I think Seoul is filled with more energy than any other city. Such energy becomes the possibilities of the future. Various attempts to connect individuals and businesses create new business opportunities, and it makes Seoul a city where creative investments are possible with advanced 5G technologies. Creative,
more dynamic,
more refreshing,
and more passionate city.
Seoul, a special city for you and me. I saw you.
여러분, 뭐 하고 계세요? 저랑 같이 서울시 인권정책길로 산책 가실래요? 서울시는 2012년 팀 단위가 아닌 과 단위의 인권 담당관을 신설하고 서울시 인권 기본조례를 제정한 것을 시작으로 전국 최초 시민인권보호관 제도 도입 운영, 인권위원회 구성 운영까지 시민의 인권 보호와 증진을 위해 제도적 기반 구축에 있어 선도적인 역할을 수행해오고 있어요. 과거에 있었던 잊어서는 안 되는 우리 인권 역사의 상징적인 공간들에 이렇게 도장을 꼭 찍어놓고 그 역사를 시민들과 함께 걸으며 기억하고 있죠. 그리고 현재 일어나선 안 되는 인권 침해를 예방하기 위해 철거 현장 인권 지킴이 단이 시민들 곁을 지키고 있고요. 또 서울시 행정에서 인권 침해가 있었다고 판단되는 사건에 대해 시정 권고를 할 수 있는 시민 인권 침해 구제위원회가 인권 침해로 인해 고통받는 시민의 목소리에 늘 귀 기울이고 있습니다. 든든한 시민 인권 보호관이 언제나 기다리고 있습니다. 서울시는 국내 최초로 시민이 인권 침해 및 차별 사건에 대한 결정 과정에 직접 참여할 수 있는 시민 인권 배심원제를 도입하여 시민 스스로 인권을 지킬 수 있도록 돕고 있습니다. 서울시는 각 분야 인권 전문가들과 함께 앞으로도 시민의 인권을 위해 계속 걸어나가겠습니다. 서울시는 서울 인권 컨퍼런스를 통해 모든 시민의 인권이 바로 서는 행복한 사회를 꿈꾸며 인권 행정이 나아가는 방향을 모색합니다. 함께 누리고 포용하고 참여하는 인권특별시 서울.
A city filled with joy. A city dedicated to its people, where past traditions coexist with the present. A city filled with creative business opportunities. Seoul, a special city for you and me. I Seoul you.
테스트 중입니다. 영어 통역 테스트 중입니다. 영어 통역 테스트 중입니다. 영어 통역 테스트 중입니다. 영어로 말하는 중입니다. 지금 계속 나오고 있죠? 영어로 말하는 중입니다. 영어로 말하는 중입니다. 영어로 말하는 중입니다. 영어 통역 테스트 중입니다. 영어로 말하는 중입니다. 영어로 말하는 중입니다. 영어 통역 테스트 중입니다. 영어 통역 테스트 중입니다. 영어 통역 테스트 중입니다. 영어 통역 테스트 중입니다. 영어로 말하는 중입니다. 영어로 말하는 중입니다. 영어로 말하는 중입니다. 영어 통역 테스트 중입니다. 영어 통역 테스트 중입니다. 영어로 말하는 중입니다. 영어로 말하는 중입니다. 영어 통역 테스트 중입니다. 영어로 말하는 중입니다.
잘 들리긴 들리는데
네.
가끔 지직거리긴 하네요.
근데 그거는 어떻게 해야 돼? 어쩔 수 없지 지금. 영어 통역 테스트 중입니다.
저희가 할까요?
네, 그러시면 제일 좋을 것 같아요.
네,
네.
저희가 할게요. 이거 쓰레기다. 네, 쓰레기다. 아니 근데 그녀의 탤런트는 그건 것 같아요. 포장.
네. 그러면은 마케팅 쪽을 갔어야지. 아니면 홍보대 행사를 가던가.
왜 자기 자신을 그렇게
근데 막
네, 2020 서울 인권 컨퍼런스
2020 Seoul Human Rights Conference. We are now on the second day of the conference, and it is now time to begin the theme session 2. I hope you have enjoyed your lunch and welcome you once again to the conference. And there may be some viewers who newly joined our conference, so for them, would like to make a few housekeeping announcements. To prevent the spread of COVID-19 viruses, this conference is being held online, and participants can join us through online. Through YouTube, you can watch this conference live with two different channels. Korean, for Korean, Seoul C channel, and for English, Seoul City channel. You can just log on to each of these channels for your convenience of language. And for the sake of the disabled, we are also providing sign language and text language interpretation. And also we have another announcement. You can upload your comments and questions onto YouTube chat rooms to pose questions, as this conference is being held online. And we are also organizing a special event for viewers. Those who are with us kindly requested to take their photos watching this conference online and upload them onto their individual SNS accounts, and we will select 100 winners to give special coffee coupons. And for further details of this conference, you can visit our official website, or you can scan this QR code on screen. And here in the studio, we have completed quarantine procedures, and we are strictly following the guidelines of COVID-19 quarantine guidelines. And as you can see, I myself and the other speakers in the studio will keep masks on throughout the entire conference. And please understand that our pronunciation may not be clear because of masks. And now we will begin the second theme session entitled COVID-19 and Information Human Rights. And we would like to discuss some respect measures to information rights and the individual's privacies while aiming at the public good of management of COVID-19. And Ms. Kim Myung-hee, Director of Center for Health Equity Research, People's Health Institute, will moderate this session, and she is now working as a researcher at National Medical Center. Moderator, now the floor is yours.
진행을 하면 될까요? 네, 감사합니다.
May I? Yes, thank you.
이번 세션의 사회를 맡은
Good afternoon, ladies and gentlemen. As introduced, my name is Kim Myung-hee from National Medical Center. And this session will talk about information human rights in COVID-19 and how to respond to protect that right in this specific time. And let me introduce our speakers and the panelists. We have 3 speakers and 3 panelists ready for the session. Well, actually, we had Mr. Kang Hee-sung as speaker, and he was indicated on the list in the beginning, but he couldn't make it in the end for today's session because he is in full charge of epidemiological tracking and operations of Seoul. And as the COVID-19 is spreading out, he was not able to make it. So let me now introduce the first speaker, Mr. Ramanjit Singh Chima. He is Senior International Counsel and Asia Pacific Policy Director of Access Now. And he's joining us online from far away. And Access Now is not widely known to Korea, so he will introduce his organization and the activities of Kividum Project against COVID-19. And he will also introduce some recommendations of COVID-19 rights infringement and protection. And the second speaker is from the UK, Professor Michael Veal. He is a lecturer in digital rights and regulation at the Faculty of Laws of University College London. And he will today talk about mobile devices-based quarantine, precision quarantine, what we call. And he will let us know about the issues and challenges and expectations that we could have from that, and also decentralized system will be introduced. And the second speaker is present here in the studio, Mr. Oh Byung-il, President of Korean Progressive Network Jinbonet, and concerning COVID-19 and the information issues will be presented by the speaker. And we have three panelists. First panelist is with us online, Visiting Professor Na Baek-ju of Graduate School of Urban Public Health, the University of Seoul. Before, he lectured at the Konyang University, and up until last June, he has worked as the director in charge of quarantine of Seoul City. He's a field worker, and he's now the president and also professor. And next speaker is a panelist, Professor Ko Hak-soo of Seoul National University. He is such a renowned expert in information right, and as you may know, the AI Law Society was newly formed last year in Korea, and he is now serving as president of that organization. Big data, privacy, IT technology, and its regulations, and these are his major areas. And last year, he reported about controversies of quarantine measures used in Korea and expectations onto some of the journals of the U.S. And that last panelist is attorney Seo Chae-wan, and he majored in law at Korea University, and he has been working as junior official and also full-time lawyer for the Public Right Advocacy Center, and he has been actively practicing and raising awareness about social rights. So except me, all speakers and panelists are such experts, so I am very glad and honored to be part of this. So I would like to ask Mr. Chima to open up the session, and then Professor Michael Veal, but as Professor Veal cannot be attending until the end of this session, we will receive questions for two speakers first, and then we'll move on to the panel discussion session and the third presentation. So first and foremost, Professor Chima, Senior Chief Chima, please.
Professor Chima, the floor is yours. Professor Chima, we can't hear you. Senior International Council and Asia Pacific Policy Director Chima. We can't hear you. Director Chima, can you please unmute? We can't hear you.
Just to confirm, can you hear me now?
Yes, we can hear you now.
Perfect. I apologize for that delay, and I will continue now. Thank you, moderator, for the introduction, and to the Seoul Metropolitan Government and its co-organizers for ensuring that this important conference continues to happen. My name is Ramanjeet Singh Chima. I work with Access Now. We are an international human rights organization that seeks to protect and advance the interests of users and their rights with regards to digital technologies in our digital age. As an organization, our focus is ensuring that globally we protect and advance human rights and the interests of users at risk. We work in the Asia-Pacific region as across many other parts of the world, and our focus often is ensuring that the most vulnerable are protected when it comes to their use of digital technologies. We recognize that the internet and its communications technologies empower and enable rights, but can also sometimes place people at risk, and we believe in protecting and advancing secure communications for all. Our work cuts across 5 areas, and we see developments on these areas during COVID-19 actively taking place. We believe it is important to work in a synergistic manner to be able to advance our digital rights and to see what opportunities we can seize, but also keep in mind the risks that are very clearly evident. One of our signature campaigns, and unfortunately an issue that has also come up during COVID-19, is the issue of internet shutdowns. As we recognize that the internet is key to enabling human rights globally, the unfortunate reality is governments across the world far too often intentionally switch off or disrupt internet access to their populations. That might seem heretical, whether it is in South Korea or India, my home country, but unfortunately, governments do so far too often, and the Asia-Pacific region sees some of the highest number of internet shutdowns in the world. Our organization also provides digital security help assistance to journalists, activists, and other users at risk so that their use of technologies does not place them at peril. Our helpline provides free assistance, and we work with a community of organizations doing this work globally to make sure that if you are a dissident, if you are a transparency activist, if you are a journalist, you can receive free assistance and you are not placed at risk by your use of digital technologies. Our helpline is often an early warning indicator of the problems and developments you might see in the larger digital space. And that has been true during COVID-19 as well. As the pandemic set in and as cities and countries across the globe began taking actions to tackle the pandemic and lockdowns were ordered or other restrictions were put in place, we saw an increasing number of incidents and requests for help from civil society organizations. In April 2020, our digital security helpline saw the largest number of cases and new tickets raised in its existence over the last 10 years, mainly because as human rights defenders and civil society organizations were forced to work from home, work remotely, their already strained resources were placed at risk with bad actors, whether they be malicious criminals or unfortunately sometimes governments as well, intentionally targeting them and placing them in a situation where they required assistance. As I mentioned, internet shutdowns, that troubling phenomena, has been an issue even during the pandemic. Whether it be India, whether it be Myanmar, where you have seen some of the longest continuous internet shutdowns impacting millions of people. These have taken place even in the height of the pandemic, right as first responders, doctors, and civilian populations needed access to information on how to treat each other, on how to take medical care, and doctors needed to take urgent action. That's why our organization, along with several others, wrote to the World Health Organization earlier this year, indicating that they must take urgent action to ensure that their member governments end this phenomenon of internet shutdowns during COVID-19. Here on the screen, you see an example of the letter that we wrote, particularly in regards to South Asian governments, including India, Myanmar, Bangladesh, and Pakistan, with regards to continuing internet shutdowns during this period, and particularly noting the harmful impact it has on refugees and migrant populations. Of course, one cannot talk about COVID-19 and digital responses without looking at the issue of privacy and data protection. From the beginning of the pandemic, from its first early stages and responses by governments, particularly in the Asia-Pacific region, we have seen the issue come up around the use of digital technologies, the collection of data, the use of surveillance mechanisms, including electronic communication surveillance and other surveillance, to monitor, track people, and share data with the intention of dealing with the pandemic, but raising significant privacy and data protection concerns. Early on, we believed that was one reason why you needed guidance to states on what they could do and not do during this period. Our recommendations published early at the start of the pandemic talked about the do's and don'ts when it came to data collection, particularly regarding the issue of contact tracing, or rather exposure notification and COVID surveillance. We recommended that states understand that this is not a binary choice. You have to take action, but you also need to protect human rights. And in fact, protecting digital rights during the pandemic also promotes public health. This realization must drive the action of all governments, whether federal governments, city and provincial governments, or multilateral organizations. Asking people to choose between privacy and health is the root of the problem. You cannot ask people to have their human rights infringed upon or given away during a pandemic. We must be able to enjoy our protected human rights as well as robust public health responses. And the response to this requires not totalitarian surveillance, but empowering rights, in the words of Yuval Noah Harari. Our do's and don'ts talk about what governments can do during this period. For example, if you are running COVID surveillance applications, ensure that they use voluntary mechanisms, including voluntary use, and that they have a sunset period, that they expire, that these applications or services have privacy, data protection, and security by design ensured in the beginning, and that they're accessible to all communities, including those that may have disabilities or other challenges. You ensure that these tools are available in open source repositories with true ability for people to see what code is being used and what data is being collected. You ensure that these services respect data protection laws that often have flexibilities for government responses, including public health responses. And you ensure with all of this that you follow mechanisms that are decentralized, that limit data storage, but most importantly, that you provide clarity, transparency, and remedy for potential abuse. It is also important to remember what you should not do. You should not be monetizing the data made available on these services and applications. You should not be making services that allow other users to access sensitive information or other personal information about the users of these services. You should not be using services and applications that interfere with your electronic devices, that rewrite or overwrite what code or what hardware they run. You should not create services that allow for unintended or unauthorized disclosure of data. You should not allow tools that are repurposed for other purposes. And you must remember in doing all of this that you should not work with firms or developers that have a poor history when it comes to protecting human rights. Because if you work with bad actors, your system and applications will open up space for abuse of human rights. It's important to remember that these issues require not just policy guidance, but robust campaigning. We must speak up to governments to ask and demand for this. What you see in front of you is a statement from April, again, the onset of the pandemic and lockdowns, where human rights organizations globally joined together to issue a joint statement on how states must use these digital technologies and what they must not do. And the realization that all of us have had, that technology is critical in saving lives and in the response to the pandemic, but it must not come at the cost of attacking our very societies and the human rights that we stand for, and making people distrustful and fearful of digital technologies. The World Health Organization has also recognized this. Many people may not know, but they actually have issued and framed ethical guidance when it comes to the issue of COVID-19 contact tracing, noting the potential value of such technologies, but also the fact that doctors and epidemiologists are sometimes divided on the exact value of the different types of contact tracing done and their use cases when it comes to digital tracing, but also that it requires specific guidance to protect human rights. You have seen a realization of the importance of being cautious about what data is being collected and the remedy made available to users in the international system. Agencies of the United Nations, deeply involved in responses to the pandemic, issued a new joint statement 2 weeks ago on data protection and privacy in COVID-19 response, which goes through the data they collect, but we believe it's also critical for their member state governments to acknowledge, respond to, and incorporate in their own thinking, including the fact that these mechanisms and intrusive data collection should not be continuing deep into after the pandemic. And as we see responses to the pandemic, including vaccine distribution and other treatment rollout, we must start being careful about what data is being collected for posterity. It is also important, as you look at these issues around information rights and COVID-19, that we look at the issue of digital identity. Digital identity systems deployed by governments, including large national centralized digital identity programs, can impinge upon human rights and far too often, unfortunately, do so. As we see more governments say that digital identity should be linked or used in COVID-19 response, we need to ask the question, why ID? Why is an identity being used? Why is a digital identity program being linked to COVID-19 response? In what manner? For what purpose? And then go into how it can actually protect human rights and what should perhaps not be done. It's important to acknowledge that biometrics and other data collection is often being used in digital identity programs. And as we accelerate the use of digital identity in COVID-19 response, it increases the risk caused by some of these approaches, including that of facial recognition technology. There must be great emphasis laid on preventing mission creep. We must not allow digital identity programs to start covering every part of human life and existence, particularly as governments roll them out during the pandemic. It is also important to acknowledge and understand that COVID-19 impacts not just privacy, not just internet shutdown and digital identity, but that it is being very much directly linked to many other rights during this period. For example, the right to protest, so key and important to all of us in democracies, is directly impacted by government responses to COVID-19, as well as the use of digital technologies. David Kaye, the erstwhile UN Special Rapporteur on Free Speech and Expression, the early holder of that post, noted the importance of how digital technologies were being used and how some of the mechanisms and means being followed by governments during this time were being used to target critical actors that make free speech and expression possible. For example, the use of fake news laws supposedly meant to criminalize and combat disinformation, being used to actually harass and persecute journalists or activists who were trying to hold government to account during this period when government have so many powers to tackle the pandemic. As we start seeing the light at the end of the tunnel, as you start seeing the possibility of vaccine distribution, of other treatment mechanisms being successful for COVID-19, we must continue to remain vigilant and cautious. In particular, my team and my organization believes that it is very important to be cautious around the proposals around digital health certificates, namely electronic records and documents about people's health treatment as well as potential vaccine distribution being used to govern how people may travel, not just across borders, but the services and tools that they can use within countries. As governments start doing vaccine distribution and other treatment, we must be cautious that these digital health certificates do not become a form of Orwellian digital identity that may be used to restrict people's rights. We have framed guidance on this topic, focusing around the importance of the right to privacy, including health information, the importance of ensuring that these digital health certificates do not impact people's right to movement and freedom of assembly, that they do not result in exclusion, namely that those who do not have these certificates are unable to access key public services, government welfare, or other infrastructure, and that they are not allowed to create a new wave of surveillance targeting individuals who don't have certificates, but also, as you may know, far too often the people who do not have access to documentation are those who are most disempowered and vulnerable in society, and that they do not help create a permanent health surveillance infrastructure that undermines and harms all of our open societies for years to come. With these thoughts, I hope you keep in mind that digital technology has been critical to COVID-19 response and will be to all of our societies post this, but we must take these urgent actions to course correct some of our countries and the international system while we can do so. And I believe there is hope for digital rights, not just today, but in the future, but it requires action from all of us. Thank you for listening, and I look forward to further discussion.
네, 감사합니다. 잘 들었습니다.
Thank you very much for that presentation. So you covered so much in so little time, and you raised some questions about what we tend to neglect. Well, you talked about the internet shutdown, that people cannot access information on a timely manner, and it is a problem that the healthcare professionals cannot access such information in a timely manner. So I think you raised a very critical point that we need to look at in terms of privacy. But at the same time, when it comes to digital technology, we need to have unfettered access to digital information. And I think that was a main point that we need to look at. So of course we have this issue of quarantine as well as fighting the pandemic. However, digital health as well as fighting the pandemic are not binary, so we can achieve both. So thank you very much for the presentation. I look forward to the Q&A session. Next, moving on to the next presenter.
지금 이제 멀리서 접속하고 계셔서
Professor Phil,
아까 안내드린 것처럼
you're joining us from far away. So as noted in the beginning, after his presentation, we'll receive 1 or 2 questions first. Please, now the floor is yours.
Thank you very much. And it's really great to be here
감사합니다.
at this conference.
저도 이 컨퍼런스에서
I would like to talk today about privacy infrastructure and the digital response to COVID-19. And I really want to build on some of the points and themes that Ramanjit Singh Chima built in his work. So we've seen at the beginning of the pandemic that there was a strong allure for the precision of mobile interventions. So we saw that many of the most successful techniques we knew how to do were very blunt, like a lockdown or a circuit breaker. And so many governments sought to use mobile phones and the sensors we have in our pockets to make this more precise. And they did so in a few ways. They were thinking particularly of using the sensors on these phones, and 4 main sensors were important in those considerations: GPS sensors, cell tower data, ultrasound data from microphones, and Bluetooth. When we think of what we can do with phones, there were various different proposals. I'm going to focus today on contact tracing. So there are some proposals like quarantine control or trying to understand flows of people, and they may have their merits, but many of those types of technologies are generally unproven. And a big focus was to try in urgency, as a research group that I was part of in particular, on delivering on an intervention that we know works. And we know that contact tracing is an important part of public health strategies during pandemics like these. When we look at these sensors, there are some serious problems with some of them. So not only are there privacy and human rights problems, but quite simply, GPS doesn't really work indoors. It's not got the right, precise enough between 1 or 2 meters to understand how people are in relation to each other. Cell tower data, also not precise enough. It can also be very legally difficult to use such data, and comes with very serious privacy implications because you're linking directly to other people's call records and so on. Ultrasound data, which uses inaudible messages from microphones, people find that very invasive and are very unlikely to want to activate that, and it doesn't particularly work on many phones. And that leaves us with Bluetooth Low Energy, which is a technology that we can repurpose towards understanding proximity between people. It wasn't designed for that, but it has serious promise. And so that was the technology, Bluetooth, that was used generally by researchers and people developing technologies for contact tracing in this context. And that's for technical reasons as well as other reasons, because the other data is just not good enough for what we need to do. However, what was not recognized enough during the pandemic is that making an app, which many governments wanted to do, is necessarily a public-private partnership. So phone and operating system vendors place restrictions on code. You can't just run any code you like on an Apple or a Google-powered device. There are restrictions that the operating system has placed on the type of code that can be run. There's also hardware restrictions. Not everybody has the newest sensors, like newest types of Bluetooth, although for Bluetooth, these are very prevalent sensors. There are also App Store restrictions. So there are soft law policies. These are policies about which apps are allowed in a store or not. There's a lot of discretion. And the reason ultimately that companies have this discretion, if I can go forwards a second, is because they've built vertically integrated stacks. So if we take the idea of Apple control the phone hardware, and the protocols on it. They control the phone's software. They control the software that is allowed to run on phones, and they control cloud services that those software use. And that gives them huge amounts of power over which software is and is not allowed to run on a device. So as a result, it's a public-private partnership when we develop any application, and that needs to be recognized because it has important consequences for human rights and for practical governance. We also, in times, have to partner with mobile phone operators in other types of public-private partnership, and that's been seen again in the surveillance realm with the Snowden disclosures and the similar concerns around those. So the lesson here is that access to this privatized infrastructure of sensors that we all have in our pockets cannot be taken for granted. And navigating that shows us maybe how we want to govern the internet in the future and the principles we want to put at the heart of it. So with that in mind, let's go and look at the way you could develop contact tracing using Bluetooth. So there are two main potential architectures, and Roman Chima indicated these in his talk as well, and I want to look a bit more closely at them. The first one, and this was proposed by Singapore earlier on, by France, a few other countries, is called a centralized architecture for contact tracing using Bluetooth. Why is it centralized? Well, we'll see. Phones in this process send Bluetooth messages to their environment. These messages are actually encrypted versions of your identity. So they could be an identity number, or they could be something that identifies your particular phone, but they relate to you and only you, and they can be used to notify you or to get in contact, and they may be linked to, as I say, your identity number, your address, other information. These are encrypted in a way that the government can decrypt, but no one else can decrypt. Each phone is listening in the environment, and it remembers the encrypted identities that they hear. So it's noted down these. And if you test positive, you send all of those encrypted identities that your phone heard to the government decrypts them, and then analyzes that data and takes an intervention on those people who were near to you. That's the idea. Now, there are significant problems with this system, because while it looks good in a very trustworthy approach, a trustworthy world, we were talking about a global system. Many countries have very limited respect for the rule of law, and we've seen function creep and surveillance creep as technologies become used beyond their initial purposes. So for one thing, centralized systems are inherently expansible. They have an identity layer here with these identity numbers that are encrypted, and these can be used as a backdoor to build immunity or health certificates, or can be used for quarantine enforcement if sensors are installed at railway stations or in shops, because it allows the state or any private actor who has relations with the state and can decrypt those identities to understand who is at any place. So it creates a large potential infrastructure of population control, and that is very different than contact tracing. So these are two different things. We note that passports emerged and were really solidified during the Spanish flu in the first part of the 20th century, and they didn't go away. So it's important to consider whenever you're designing a system in a pandemic that these infrastructures might not go away, and we must design them to be human rights respecting by design beyond a pandemic or an emergency situation. We also know that social graph data is really sensitive. In a centralized system, a centralized actor like a government has a map of who saw who in society, whether that was a risky contact or not. And that kind of information can be used to understand detailed social networks, can be used to understand where dissidents and whistleblowers are, for example, or political activists. So this data needs to be heavily protected, and we need to avoid collecting it if we don't need it. Some people might say we need this for public health, but indeed there is actually no information or no evidence that Bluetooth social network data is useful for tracking the viruses. And we had in Switzerland our team of epidemiologists looking at this and considering this. And Bluetooth data is very, very bad data. It's not very good for detailed analysis of exactly who saw who in what situation or where the virus flowed. And we must be realistic here and only use proven approaches, and contact tracing is proven, but the idea we collect a huge amount of data and sit on it when that data has other risks, particularly in countries around the world with limited respect for human rights. That's something we need to think carefully about. Lastly, contact tracing systems rely heavily on adoption. Some countries may feel comfortable with mandating their citizens to use this system, but many countries will not be able to do that in terms of culture or constitutionally, and we may not want to do that for human rights reasons. So we need strong privacy protections and protections against abuse to ensure that everybody feels comfortable using these systems, including marginalized communities who are typically surveyed in much more serious and constant ways. And we see that those communities, because of their precarity in general, can be important in spreading the disease because they can be neglected in public health strategies. So it's important that we maximize adoption, and privacy helps you maximize adoption throughout society. So with colleagues in around the world, I was part of a team developing an alternative. And this alternative is a decentralized protocol. In this protocol, your phone sends not encrypted IDs, but random numbers into the environment. And these numbers change all the time. So these numbers do not decrypt into your identity or your identity number. Your phone remembers those numbers it sent out, so it has a list of those, and it listens for those that others sent to your phone. When you test positive, you send the random numbers that you sent out to everybody else's phone. You communicate those, so everybody's phone gets a download, say, oh, these numbers that were random, they meant nothing, are now added to a big list of numbers we now know relate to people who tested positive. And your phone, without using the cloud, without using a central server, on each device in the country, checks the numbers they received from the numbers that you have detected in the environment and looks for any overlap. Did you see any of these people who we now know could have put you at risk? And if so, your phone notifies you and lets you know. And if needed, your phone can send your phone number to a public health authority who can contact you. What this does, however, because everything happens like a jigsaw on everybody's phones, there is no giant central database of social network data that is unnecessarily collected. This is a neat scheme that works without that data, but still has the same effect. Now, a note that we'll come back to in a moment. Your phone never needs to send the numbers it heard to anybody else. So it only needs to send the numbers it emitted, it sent out, never the numbers it heard. It always stays on the device. And that becomes important, so remember that. So we thought as academics that we wanted to make sure that at the beginning of the pandemic, the options were on the table for governments to choose. And we thought we can't stop people using digital technologies for COVID-19 interventions, but we can present an alternative. And we can argue that that alternative is better for epidemiology, and it's better for privacy and control of power and human rights. So we created a decentralized system and we published it, and we thought it was a feasible task to try and present an alternative option. We had a big group of universities particularly around Europe, and it was called the DP3T project, Decentralized Privacy Preserving Proximity Tracing. And we didn't sleep very much. We released our system in the beginning of April. It was led by Carmela Troncoso at EPFL, and she's really fantastic as a privacy engineer. And we had the epidemiology lab and lots of other collaborators around the world. We wanted something that worked on phones, so we needed to only use sensors that were available, minimize risk, and can be gracefully dismantled. So when the pandemic ends, it collapses on its own. It doesn't stay, and it can't stay. Prevents tracking and abuse, and is designed for and with epidemiologists. And it was, in the end, there was a picture of this app on Mr. Chima's presentation as well. It became the Swiss COVID app, and many apps around the world got based on this code. Now, that's not the end of the story, because an important part of this story was the role of platforms. So platforms, thinking about Apple and Google again that I mentioned before in the public-private partnership of app creation, they made a choice. They control almost all the smartphones on the market. Apple in particular does not let phones use Bluetooth in the background for very long when the app is not on and on the screen. So any contact tracing app by Apple requires an operating system change. They make that choice for privacy and for battery life reasons, so there's a mix. And Google phones can have similar problems. So any contact tracing app that used Bluetooth required buy-in from these platforms to change the operating system of all their phones. And Apple chose to build new functionality that only enabled decentralized systems and did not enable centralized systems. This is because, if you remember earlier on, centralized systems require phones to send out the numbers they heard, and decentralized systems do not. Apple used that fact, and they only allowed phones to send out the information that they had emitted to other phones, and never send out the information that they had heard. So that could never be sent to the government, which had the key to unlock it. And so only decentralized systems were allowed to work on Apple phones by code, regulation by code. Some countries had already built decentralized apps, like Switzerland and Austria, and Japan as well later. And therefore, they just continued with building those apps. Some countries changed to use decentralized apps when they initially had plans for centralized apps, such as Germany or the UK. Some countries didn't change, particularly those that had very high Android penetration, because they could roughly make a centralized system work on Android phones. So many countries in the global south have very high Android penetration and didn't feel a pressure to change because Apple was the main reason that you might want to change. Now, some would say, did Google or Apple determine the public health response? I'd say that's the wrong kind of question. We're actually living with the consequence of not regulating for openness on platforms, because countries have let closed ecosystems on smartphones happen for far too long. We are not allowed to run code that has not been sanctioned and permitted by platforms on these devices, these smartphones. We're not allowed to. So this is totally expected because it's a public-private partnership. So we need to think, my last slide, on where we go from here. Are we comfortable or uncomfortable with that? Are we comfortable with platforms like Apple and Google having so much power over the type of code that individuals can choose to run? Not necessarily governments, but just individuals can choose to run on their phones. I think that we may need to think of an international agreement for the openness of computing systems, the openness of ecosystems. But this also requires us to have strong privacy and information law, because if anyone is allowed to run any code on their phones, that can also be used to coerce people, can be used to make them give data they wouldn't have given otherwise. Individuals should not be treated like robots, and they shouldn't be treated like sensors. Governments cannot and must not assume that just because we are carrying phones, they have a right to deploy anything on them at all and to use these sensors in any way whatsoever. So governments also need to support digital human rights in order to be trusted. So when they ask people, you have these powerful sensors on your device, please let us use them for the common good, then they have that trust automatically. If they don't, we know that interventions will fail. We know that if people don't trust things, they will stop taking these phones with them around. We cannot coerce people in the same way. And we have to bear that in mind. So as I say, some cultures, people are more, at the current state, people are more willing to go along with government. That might not last in those countries, and that doesn't last around the world. We need this to be considered in a global situation because we're talking about global pandemics. Whether coercion is from platforms or from governments, everyone loses. So we have to think both about designing, as we did in DP3T, for human rights, but also designing our broader computational ecosystem for openness. And thank you for inviting me and allowing me to talk. And that's the end of my presentation.
네, 감사합니다. 잠깐만 그럼 혹시
Thank you very much. We would like to put some time for questions or comments to the speaker. Yes, Mr. Ko. Well, this is a simple question from Professor Ko. DP3T, you have briefed about that alternative. It was last March and April. Well, this has been implemented. This has come to life briefly from a short discussion. But by looking back on that technology, how how would you preliminarily evaluate the procedures or the process of adoption of each country up to now? That's the first question. And I myself also have a question. Well, regardless of Apple and Google, and if we use their platforms, in case of Apple, for example, Apple should have an openness on the background to gather data. Well, that back-end operation, if that is open, then don't we have any risks of having other technologies or other OSs penetrate into the system? I'm not an expert, so I have that kind of simple curiosity. Yes, these two questions, please.
Thank you. And I think the nature of your question shows that you are an expert in picking out interesting things to point about. So firstly, we're obviously still evaluating these technologies. Adoption is quite high in several countries, in the UK and Ireland, for example, and that's very positive. It's really high in urban areas as well, which is where you actually need people that are very close and you need to use these technologies. Where we've actually seen challenges is the integration with the health system. So some people have thought, oh, you built a privacy protecting system. The reason we haven't seen these as completely solving the pandemic is because you didn't collect enough data. Well, that's not actually true when you look at what breaks down. The breakdown is people getting the codes, people understanding the user interface, using the apps in those situations, and then being integrated with the health systems. We pointed this out very early to governments to begin with and said, you need to do one thing really well, and that's proximity contact tracing in this context. And you need to integrate it with the health system properly. So we do see in many cases it's that integration which is causing the challenge. But we've got initial data from the Swiss context which shows it's been an effective aid in complementing the fight of COVID-19. But as you will very well know, it's very difficult to ascertain causality in these complex interventions and situations. And what I think we've shown is that techno-solutionism is not the way to solve this pandemic. Many governments were worried about thinking, oh, we can use technology to solve everything. And no, it's an important tool, but it's only one small tool, and we want to put it in its place. It should only be a small tool. And in relation to the question of the moderator, you're totally right. This is why we need strong information regulators, because if you open up code for anybody to run anything on, it does create security challenges. And we see tracking can be used inside game apps or inside in other apps that people use. Even sensitive apps like we've seen apps recently, the Quran apps have a lot of trackers in. Also period trackers, menstruation trackers. Also, these free apps have a lot of trackers in. So we have to protect ourselves against these too. So we need processes to control apps on app stores, but they must also allow people, if they want to run software they like.
네. 혹시 또 다른 질문들 없으시면
Well, thank you. If there's no other questions, we will wrap this up here. Thank you very much for joining us at very late at night there. Thank you for joining us.
지금 마이클 베일 선생님이 얘기해 주신 것은
Now, as Mr. Vail has mentioned, there are many technologies that we can use during the tracking process, and also he talked about some problems that can be caused by the centralized system.
And as an alternative, decentralized Bluetooth-based mobile technology and system is touched upon as an alternative, and it was quite technologic, and it's not commercialized yet, and some pilot tests and projects are under operation in some cases, countries, so it seems that it is too premature to evaluate this alternative in earnest. And moving on, would like to invite the third speaker.
Yes, good afternoon, everyone. My name is Oh Byung-il, president of Korean Progressive Network called JimboNet. So thank you very much for the two presentations from overseas. So we heard the global cases. I would like to talk about some of the issues and challenges that we faced in fighting the pandemic. So I would like to mention about 4 issues that we faced. First of all, I would like to ask some questions. So I've been an activist for the past 2 decades, and sometimes, I'm faced with a lot of challenges. Now, Korea is struggling with the 3rd wave of the pandemic, but in overall, Korea is being recognized as an exemplary country in its fight against the pandemic on the global stage. And that was driven by the accurate tracing, as well as identifying and responding to the pandemic. But then, do we have to rely on the surveillance system, just like Korea, to be able to cope with the pandemic? Of course, GPS could be used for tracking. But then, accuracy level is low when compared to the infringement to the privacy of the people. And now, Korea has started to use CCTV more extensively to overcome such criticism. Then, to deal with the pandemic, we will need surveillance to a certain extent and thereby infringe privacy to some extent. But is that the only option? So with that question in mind, I started to look into the quarantine guidelines by the Korean government and identify some areas of improvement. So in fighting the pandemic, did the surveillance system really contribute to coping with the pandemic? And if yes, do we have to just accept it? And or if we were to go with the surveillance system, can it be more human rights friendly? So those are some of the questions that I have in mind. First of all, we need some standards to make evaluation, and we do have the Syracuse principles that I'm sure that you're aware of. This is for the human rights. And we also have many agencies and human rights agencies that set forth some of the guidelines that we must follow. And yes, we could limit human rights to a certain degree, but it has to be justified. It cannot be overly broad measures, and it has to be for a limited duration, and also applied when only strictly necessary. So we do have some acts in Korea to protect personal information, and the first one would be the Personal Information Protection Act. However, in times of infectious diseases, we are applied by the Infectious Disease Control and Prevention Act. And when it comes to the personal information processing, everything will be done following the Infectious Disease Control and Prevention Act. But if we look at the Article 8 of the Personal Information Protection Act, of course, 58, there is the personal information process temporarily where it is urgently needed for the public safety, security, such as public health, etc. And so now, in times of the pandemic, we rely more on the Infectious Disease Control and Prevention Act rather than Article 58 of the Personal Information Protection Act. And Songdong-gu office also has applied a device to recognize the faces of the people. So it's a facial recognition technology, and also to measure temperature. So now that does not fall under Article 58. And because of that, the recommendation was that we should not use the facial recognition technology. Now moving on to the contact tracing of infectious disease patients and the collection of personal information. We have to conduct epidemiological investigation for confirmed cases, and we have to track their travel map for the past 2 weeks, and that's according to Article 76.2 of IDCPA. And that's not just personal information, but also entry to the country information, as well as the travel map, as well as the credit card transactions and CCTV information. So we also have an ordinance for that, and the central as well as local government can do this. And the agencies as well as different groups and individuals can be subject to provide such information. And this is done in other countries as well. However, Korea stands out in that when collecting additional data, Korea goes a step further. It, for instance, conducts interviews with the confirmed cases. And at the same time, well, now with COVID-19, we have this epidemiology investigation process. So before, the government relied on telco companies or financial organizations to receive data, but now the government takes a more aggressive role in collecting the personal data and track and trace the travel map of the confirmed patients. And we also have a system where all the map can be seen on a single computer screen. However, the problem is that these are all sensitive personal data. So not only my illness information, but also, let's say, my travel path. So the public institutions can identify where I've been for the past 2 weeks. And there are some times when people lie and they receive harsh criticism from the people. However, should the individuals be held responsible for this? So let's say that, for instance, you go to church and then you become a confirmed patient, and this person could not disclose that he was in a church. However, well, going to a church is not illegal. However, there are certain information that sometimes you do not want to share with others. But then this person had no choice but to hide the fact and lie to the authorities, because everything was revealed, the travel path was revealed, which was subject to people's criticism. So that was what was happening in our society. And because of that, this person had no choice but to lie about where he had been to. So we cannot just point fingers at the individuals. We need to share the burden and responsibility. Also, we have to look into the scope and extent of personal information collection. And now this relies on the autonomy of the different authorities. So what we are doing right now, we collect information not only of the confirmed patients, but also the suspected cases. patients. But then how far are we going to define suspected? And we see this very vague definition of the scope. So that those would be suspected cases would be the people who might have been in contact of the confirmed patients and might have contracted the disease. However, we usually rely on the telco base stations to identify those contacts. And one example would be the Itaewon Club linked surgence of the virus in early May. At the time, Seoul City and Korea's CDC requested personal data to the telco company to receive the information of the people who were near the club. So what they did was they received data of the people who were around their area from April 24th to May 6th around 5 a.m. In Itaewon neighborhood, and those who stayed over 30 minutes in that neighborhood, and the number was over 10,000. Then can we say that the 10,000 all fall under the suspected patient category? I think that is an overreach. So, since there was a confirmed patient on May 2nd, was it necessary to get information from the people and travel back to April 24th to collect all the data? I don't think so. Then, instead of doing so, maybe the government could use different sources of data. And in July, that is why there was some activist who appealed at the Constitution. So now, how are they managing this type of information is also very unclear. So we asked some questions with respect to this. So this is about the management of the collected personal data. And there's no regulations for disposing of information collected under the Infectious Disease Prevention Act. However, it is ambiguous whether the collected personal information will be disposed or not, even after the virus is behind us. And what about MERS? Are they still keeping the confirmed patient information collected at the time of MERS? Well, they're still keeping the information of the confirmed patient back then. And for now, we don't know when the COVID-19 pandemic will be over. So we don't know whether the authorities will keep the information for how long. So of course, once we have the vaccines, we will see much less cases of COVID-19. However, we can tell for sure when this will be over. And unless we can specify when this will be over, then we might as well think that the authorities might keep this information forever. So this is about the management of collected personal data. It says this was released by lawmaker Jung Chun-seok. And this includes information about the infectious disease on the web and the personal information that the authorities collect once we have confirmed cases. And the authorities have so far collected more than 2 million cases of patient information. And they also have the personal information of the contact. And is it right to keep this this information and not dispose the information? So we could raise such questions. And although this is to curb the virus, how are they managing this, and what rights and authorities do governments have? I think we need to have strict guidelines about that. And also, next, I would like to talk about the disclosure of movement path of confirmed patients. So because of that, of course, it does not release all the personal information. It only discloses partial information, but still, many people were subject to harsh criticism after their travel map was disclosed. And on the right, you see some of the text messages that we receive from the government. And you see, you can identify that this person traveled here and there, and by such information, people can just assume that this person works for a karaoke. So that can actually infringe that person's human rights. And some people are even more afraid of having my travel map released than catching COVID-19, and the same goes with me, because this type of travel map can really incite the curiosity of the people. And of course, we conduct epidemiology investigation. However, we need to do more to find out where this person has been. So if we were able to identify all the contacts, then we wouldn't be needing to do this. The good news is that the Human Rights Committee in Korea made some recommendations, and there have been 3 revisions about the travel map and the information revealed. So for instance, gender, age, and nationality should not be disclosed, and the address should not be disclosed. And when all the contacts have been identified, then there is no need to disclose the travel map. But then, now let's say that the government, the authorities only need to disclose a certain timeline and the neighborhood of when the confirmed patient was visiting that area, and that is more than sufficient. So this would be one of the examples that I would like to propose as a method to disclose people's information. So this is one example, disclosure of where the people have been, but still now the local governments are not following these types of guidelines, and they're violating the guidelines on the disclosure of the travel path. So this is from Seongbuk-gu office. So here you see they disclose the movement path by patient. So you see the number of the patient and the movement path. And for Changwon, Changwon follows the protocol of Korea's CDC, but then it also conducts daily briefings and disclose personal information of even students. So we have much room for improvement. And also the next part is surveillance for the self-quarantined people. And we have different ministries operating different applications to monitor these people. So for instance, we have one from the Minister of Interior and Safety, and the other one from the Ministry of Health and Welfare. This is the wristband for the self-quarantined people. And actually, this was opposed by the human rights groups. However, the authorities pushed this idea. but then still they have made some improvement by coming up with a legal ground. And I think that this should be based on personal consent. However, that is not the case for now. But anyway, if we were at least to do so, then that is a step forward. So far, we have introduced these types of technologies for the criminals. But then who will be the next target for this type of technology? So we have so many obstacles. And for instance, now the wrist monitor is only used for those who move outside of the range or tamper with the band. However, this assumes that everyone in self-quarantine can be potential criminals, so it has much room for improvement. Next is the mandatory entry log system. So now we either use a QR code-based system or handwriting, but of course that matters. But the problem and what we need to focus on going forward is that, of course, all the data is now decentralized and is kept in a decentralized manner, but it is kept somewhere. So we have to address that challenge as well. Now, moving on to the conclusion. So I talked about the principles of the human rights, and I said that we need, of course, to follow the principles of efficiency and so forth. However, so far, the health authorities as well as the government made the decision on their own. However, they have no monitoring system or governing body that oversees what these authorities are doing. So we need to have an independent system for that. And Korea was able to succeed with K-quarantine thanks to their close social network. For instance, we have the social security number system, we have the cell phone, real name system, and universal system, and monitoring system, and so forth. However, we have to be aware of what we can do going forward to improve this. And these are used for public good, but this could be misused at some point, which is why we need to really add some democratic values here and provide with some legal ground to make some improvements. And of course, we need to have social discussions and debate to reach consensus. But now this is being used as a mere campaign by political parties. So we have to address that as well. Then this is the question that I would like to pose. Did the K-quarantine succeed? I'm not saying that we failed. However, we have to examine more closely where we succeeded and where we failed. And of course, we say that the monitoring system really succeeded in Korea, but then how much did that contribute to quarantine? I mean, interviews are not enough. Did we need additional data, or maybe masks could by itself, be very effective? So, is reducing the number of confirmed cases enough? And now we have to look into the economic as well as human rights and healthcare dimensions when fighting the pandemic. And if we take those factors into consideration, we cannot say for sure that K-quarantine was a success. So going forward, we have to base our K-quarantine model on human rights. Yes, thank you very much for that. You talked about some sticky points with respect to what's going on in Korea, the tracing of the patients and contacts, and about the travel map, and number 3 about the self-quarantine application, and number 4 about the visitor log that authorities are now requiring. So thank you very much for that detailed information. And of course, this is the responsibility of the experts as well as some bodies, but at the same time, it needs to engage the civil society, and we need to come up with a strong governance in terms of human rights. So thank you very much for that. Now moving on to the panel discussion. We first have Mr. Nabekju.
So you're online, right? 10 minutes are assigned to each panelist, and we will have 10 minutes left for a general discussion.
시작하겠습니다.
Okay, let me now begin my comments.
잘 들었습니다.
Thank you very much for your discussion and presentations.
여러 가지 중요한 팩터.
For quarantine, we have many determinants.
저는 무엇보다도 시민들의 참여가 방역의 완성에서 굉장히 중요한 부분이라고.
But I personally think that citizens' engagement is the final touch of the completion of quarantine, like wearing masks, cooperating with epidemiological researches, or responding by exercising self-isolation or social distancing. Well, when we implement comprehensive quarantine procedures, it is obvious that our daily lives are somewhat controlled, but the citizens' cooperation is the key to the success of quarantine. Well, the government do not impose any penalties or fines on not respecting, not wearing masks or not respecting the rules of self-isolation or self-quarantine, but voluntary citizen participation or engagement is the one that made K quarantine a success. Well, by listening to presentations of speakers, well, the crisis moment, well, the thought about this critical moment is important, and of course we need to respect and protect the rights of confirmed cases or potential patients, but we also try to strike a balance between protection of human rights and administration, because the more information is needed for a more efficient prevention of the disease. Otherwise, the vulnerables will be led to death. And May this year, one of the academic lecturers at Incheon got confirmed, but during the process of treatment, he made some lies. So that made everyone to they overconsumed the time and resources. So epidemiological research is on the basis of fact statement by the patient, has its own restrictions and limitations. So this kind of conflicts between people who try to cover or not divulge their contact info and movement info is observed very often. So that's why governments try to use GPS information, CCTV, or card details and medical records, and these are used efficiently, and this can suppress the spread, the practical spread of the virus. That's what I see. But I also understand that there is a high probability of of infringing human rights in doing so. That's why, concerning this part, we need to take advantage of meaningful legal information against administration to implement administrative measures, but it's also necessary for the local communities and municipalities to establish a support system in an instant way to support the legal judgments on site. And in line with that, the governance system that allows the participation of civil societies and the human rights associations and infection experts, so that we can provide other alternatives for an emergent cases. And this may, when we had many confirmed cases from Itaewon Club, we held a consultative gathering with experts and related stakeholders to receive their feedbacks and to operate the test procedures in a way not to intervene or infringe the human rights of the minorities. And this positive case should be benchmarked to continue the kind of approach. And Mr. O also mentioned about the appeal to the Constitution concerning the telecommunications centers, the signal centers of Itaewon, and I understand that that part has just ended with a simple divert of the information, and we do not know since when the confirmed case, the confirmed people have been in contact with others. So there are some excessive approaches that have been implemented and failed. And also during COVID-19 in Daegu, there were many confirmed cases in Daegu in February, and the control of central government was not operating properly. Without municipalities' responses, I am not sure if we were able to respond properly to Daegu incident, but thankfully, medical facilities of the municipality have responded well, and also the voluntary participation of citizens helped a lot. Local communities do have some lack of appropriate approach to the disclosure of information, but I also sense that ordinary people would like to know excessive information of confirmed people, and that causes conflicts. And also, up to now, we have tried to respect the guidelines of the Infectious Disease Control Center, so we need to strengthen our strong points and enhance our weak points. And also, National Commission on Human Rights and seeing their manuals against the disasters and emergency cases, I think it is necessary for them to review their manual. And in terms of tracking the infectious disease and human rights, if we could divide this agenda into infringement of human rights and minor human rights, then I assume that the infringement of right to information in Korea is not that a big issue. As the representative of Access Now has commented, government is somewhat not on the basis of guidelines and legal foundations, and they do not seek for any profits. So as we do not have legal foundation, if we could make a industrial and police support for the public health, and if we could be in line with governance system in cooperation with the human rights associations, I think we can do a better K-quarantine concerning the disclosure of individual information. Thank you very much. Based on his own experiences on site concerning the process of quarantine, he has just mentioned that the data is important and the data can be efficiently used, but not only scientific approach, but also political issues like citizens who want to know more information than needed. And he also mentioned that there are practical restrictions that we get exposed to. And as an alternative, he recommended governance structure or where civil societies can be participating in. Well, we'd like to move on to the next panelist.
Yes, thank you very much, presenters and panelists, for the presentation and the comments. So it was a great opportunity to learn not only the Korean cases, but also the global cases. So I would like to mention 3 points in the context of privacy. So, of course, we have the Personal Information Protection Act in Korea, which relates to privacy. And I'm sure that almost all the adults in Korea know of the act, and they know that privacy is important. I think the level of awareness when it comes to privacy is pretty high. However, it's been less than 10 years since this act was enacted. So this was enacted back in 2011. So it's been less than a decade since we've had this act for personal information protection. And except for the recent few years, not many people were quite aware of the concept of personal information and whether there was an act to protect personal information. So by that I mean that COVID-19 has posed a question with respect to how we are going to view personal information. And it's a basic right under our constitution, and it's one of the fundamental rights in Korea. And how is this different from other fundamental rights, and where is this situated in the larger context? Now people have started to pose such questions. And Mr. Oh Byung-il gave a few examples. One example would be the right to religion as well as to occupation and to assembly. And these are the fundamental rights. And Access Now CEO also mentioned right to protest, and of course we have to have such right. And these are not well stipulated in the constitution. But what about the sexual identity? This is also a very fundamental right that we need to cherish. So I'm not saying that this is the answer that I'm providing you. However, how are we going to do with the conflicting values? I think we are now at a crossroads where we need to really seek ways forward. And this is a long-distance race. And Mr. Oh said this very vaguely, but there was this person who was afraid of disclosing that this person went to the church because he did not want people to find out about what he was doing. And well, you know, there are some public officials who are afraid of disclosing their travel map because they might lose their jobs. And I've actually read some articles about that. So having your name on the list and disclosing your travel map can actually threaten your livelihood. Then how are we going to assess this type of outcome? That's a social matter that we need to look at. And as for the Itaewon Club-linked infection, well, you just mentioned the minor and major human rights violation, but I'm not sure whether we can use those terminologies, minor or major. But then in law, we use the comparative sentencing. So by that, I mean that the sentencing level can be different, and everything comes down to the proportionate principle. And you said, we have to apply this to an extensive level, but how are we going to define extensive? So that is also a question that we need to find answers to. So we need to strike a balance in such a process. And we heard this example about the church, but then there was the Shincheonji church cluster infection in Korea. So there were many incidents linking to churches in Korea. There was the one linked to Itaewon Club. So some physical spaces. At the same time, there was the protest in Gwanghwamun Square. How are we going to interpret the freedom of assembly in that context so we can raise such questions as well? So there are so many individual cases that we could examine to find answers to, and the court cannot provide an answer to all of these problems. So it would take about 3 to 6 months for a court to reach a decision. So we cannot just rely on the court for the decision. And of course, some of the injunctions may lead to faster outcomes, but still we need some time to wait. And you also talked about, Mr. Oh talked about the disposing of the personal information. But then the Prevention Act for Infectious Disease, it's a separate law other than the Information Protection Act. So that act is only applied in very extraordinary circumstances. So what we need to do here is we need to go back to the basics and look into the clauses of the Personal Information Protection Act. The basic principles are all spelled out in the Act. But what is disappointing here is that these are very valuable information. Can we just dispose such information that it could lead to such a question? And sometimes, such information could be used for research purpose as well as other purpose. So, but then at the end of the day, it has to be legitimate, and we need to have a legitimate rationale behind using such data for research purpose or other purposes. And of course, there is this regulation on the anonymity of the information, and we keep revising the laws to meet the demands of the times. So let's say that we will use this for a research purpose only, or we will make this anonymous so that it falls outside the boundaries of the Personal Information Protection Act. So we will pre-process such information. So we need to make a decision in really taking actions. And now there are so many private researchers that upload information on their own website, and they stopped doing that 2 to 3 months ago because, to the best of my knowledge, it would be such a hard task.
그와 관련해서 데이터가 상당한 데이터가 쌓이고 있는데
The CDC in Korea has a massive amount of data, and can CDC just keep such data?
그런 상황을 고려해서
And of course, we have to take the Data Protection Act into consideration. And we have a scheme called Personal Information Impact Evaluation. So I think we need to evaluate the impact on the personal information. And at the same time, of course, it is stipulated under law. But on the other side, it would be used as a critical mechanism to gain trust from the public. So we have to look into the different mechanisms and the underlying elements in the Act. Last but not least, we use QR code to visit stores. And with the adoption of QR code, the personal information will be stored in different online platforms such as Kakao and Naver, and the restaurants or the other stores' information will be stored in Social Security Information Institute. So we have two different sources of information. And I think it was a good idea to store the information on different databases. But at some point, the data will be matched and they will be integrated. So we have to look into where we stand in that aspect. Is it just a few of the entire cases, or is it thousands or tens of thousands of cases? And nothing has been so far disclosed to the public. So we need to be transparent. So together with the impact evaluation that I mentioned, I think we need to look into the idea of transparency. Yes, thank you very much for the comment. You asked many questions. I think we should all think about such questions. I mean, they don't have the right answers, but it's something that we need to look at. And COVID-19 has raised many questions about the fundamental rights under the Constitution, as well as the crisis of healthcare. When these two values clash, where will we find harmony, and how are we going to solve this? So you raised many questions. First of all, there was the disposing of the data and the integration of the data. So what is the process of integration, and what is happening there? You mentioned transparency, and well, I majored in epidemiology, so data processing is critical here for us to get better prepared for the next pandemic. However, in that process, we need to be very cautious, because let's say that now we say that we are only going to use for epidemiology investigation, but then what about the next step? In what research will they be used? So we will need some sort of very strong governance and consensus with the civil society for this. So thank you very much for that.
혹시 더 토론할 게 있으면 얘기해 보도록 하겠습니다.
Well, let's listen to the last discussant.
안녕하세요. 서채환 변호사라고 합니다.
Good afternoon. I am 서채환, attorney.
분들 많은 이야기를 해주셔가지고.
Well, thank you very much for your valuable comments and discussions, and I'll try to be brief and concise. Well, Professor View.
그냥 이제 취득하는 그런 방식으로 하는데
Well, unlike us getting GPS information naturally, Professor View has proposed some alternative initiatives using Bluetooth. Well, it gives an implication that when we collect information, we violate the laws, because we have never considered the alternative consideration. And I personally attend diverse seminars, but there there's a prevailing ambience thinking that Bluetooth-based data collection is not an appropriate way. I mean, it's not a good way in terms of efficiency. So we fantasize K-quarantine, and in some senses we make the principles of human rights blurred. I would like to point out that point. And concerning the presentation of Access Now, I agree that there are some areas that we need to look over. Human rights are connected, as mentioned by the president of Access Now, and one aspect of human rights doesn't mean that aspect only, because the infringing the rights of privacy means that looking at it from the perspective of international laws and regulations, it could be well, let me take an example of Itaewon Club, and his sexual orientation was unintentionally diverged and communicated to his surroundings, and we can't call this a minor human rights infringement or major infringement, because we need to respect the dignity of all humans when protecting the human rights. So we can't say that we can't categorize human rights into important matters and less important matters. And secondly, when we understand the rights to privacy, that should be understood going beyond the scope of freedom, because all human rights have rights to respect, rights to protection, and rights to execution. But for example, when adopting a new technology in Korea, that technology is just fastly adopted to the market, not considering the rights for human beings. Well, we read an article that safety net is not well established for self-isolation, but during the past month, all people of Korea have been using the information the information app or tracking app without safety net, but nobody criticizes that. On the contrary, that app will be awarded. So the excessive adoption of technology, including tracking app, there should be a standardized and considerate approval or certification. But in an emergency situation of the infectious disease, the regulatory proof is not sufficient, and this situation cannot be seen as the situation of conflicts. Let me tell you about an international regulation. Well, according to the Article 14 of the Commission on the Social Rights Enforcement, the public health should be done for the protection of information rights, but the assumption is that there should be a conflict between protection of human rights and disclosure of private information. But privacy or private information is a basic right at constitutional level, but we can't make any claims to this for now. It means that the basic rights are not protected by the law, but under the under the ambience of emergency case and under the fear against infectious disease, no one is making a claim of this, and the principle of proportion is not applied to this. And in an emergent case of COVID-19, raising awareness or raising questions are connected to hatred, and And I also heard that many information is needed for the research of epidemiology. But what's most important in COVID-19 case is the flow and movement and the fact statement of the person related. But we say that the data should be collected because we can't have a full trust in person, but does it justify that we have to have excessive information collected from individuals? There's a quarantine system for COVID-19, but collecting all information is clearly against the criteria of international human rights. So what should be considered first in adopting new technology is how to detect the probability of profiling and how to protect the subject of information and how to put in place protective measures. But there's no enough legal foundation. There's a guideline, but there's no foundation legally. So that's what was touched upon by Professor Oh, and that's against the Syracuse principle. But as mentioned earlier, Syracuse principle should be guarded and protected, but that's not enough for COVID-19. Going beyond the Syracuse principle, how human rights are associated and how the infringement in privacy right is connected to other human rights protection, that should be discussed. And also, as Access Now has commented on this part, the adoption of new technology and the collection of information are subject to make impacts on the vulnerable class. And recently, due to COVID-19, the usage and the demand for social welfare system is increasing, and the excessive administrative measures are exerted on people who would like to legally take advantage of these services. But what's most worrisome is that such collected information could be used for the investigation of the vulnerable people. Whether the information collected from Itaewon's telecommunication station was used for the investigation or not, and if it is justifiable or not, if it was indispensable or not, and these questions should be addressed. Well, we do not respect anymore basic constitutional principles under COVID-19, and in that sense, COVID-19 is a crisis, and how to respect basic rights and how to advance to protect basic rights and human rights and how to put human rights in the center. And those questions should be addressed primarily, regardless of for Korean Constitution or international human rights regulations. Well, I am not well arranged in my comments. Well, we can't approach this private information disclosure matter as a kind of annoying issue. Well, without my consent, my right to privacy is not well and appropriately evaluated, and how much impact is imposed on my human rights is not contemplated by anybody. And our constitutional court has already been in discussion for this matter. And why is the protection for privacy needed? Because it regards sensitive human rights and discrete private lives as well. And once infringed and violated, this will make a direct impact on our daily lives. And that's why we need to think of our own rights from now on. Thank you very much. Regarding a new technology, as we do not know many details of that, we have a kind of illusion. believing that the new technology will solve many problems that we have, like a safe band and self-isolation. Well, we do not know how they are operated internally and how data is operating. So without knowing that kind of information, we just simply believe that will be helpful for quarantine, and that's why we give waivers of our rights. No citizens has officially announced that, but there is a social ambience of accepting being collected, in terms of my private information. So was it appropriate? Was it efficient? And was it responsive enough to protection of human rights? Well, we haven't asked those questions. And actually, quarantine and the rights of information and the privacy of individuals, and these are not separate matters, and these are closely tied, and it's now look back on those overlapping points, and we can't continue this situation on and on. And I hope that this conference will be a trigger to draw discussions and contemplations. Well, I know that Mr. Chima is still with us online, so do you have any comments to make?
Thank you for that. I just would say that many members of the panel, as well as the previous speakers, have talked about the important challenges that have been at play in this. Most notably, Professor Veal's comments on the fact that they are design and technology decisions you have to make at the beginning. There's been a rush to come out with many technological and data solutions. Sometimes there is a degree of this fetishization of technology, that technology will solve everything, whereas we still have very real, hard social, public health issues and public service issues. The other thing that I take away, and I would say, is that a lot of us are trying our best to do what we can and to do the best that we can. That makes it sometimes harder to have these frank discussions with, say, government officials or even doctors sometimes, that we understand where you're coming from, but is the solution you're proposing really helpful, really useful? I will just pause for a second and just reflect on the commentary I saw in April and May of this year, where a lot of people noted that some of these solutions, not just contact tracing apps, but other digital solutions, were being pushed by technologists who felt challenged, who felt frustrated and powerless in the face of the pandemic. The fact that we're all having to change what we're doing, that we're all restricted by what's happening, and we have this urge to do something, which is a good urge, but sometimes you might encourage solutions that are not effective, that are not useful, and long-term may cause other harms. The other point that I would note that many of you are pointing out is that we've seen a lot of usage of technology. One of the challenges has been to always establish, has it really served that purpose? The comment I would make as a public policy person is, once you create a system or you create a regime, you are also invested in defending it and in saying that it was worthwhile, which makes it very hard sometimes for people to acknowledge the mistakes that might have been there. But I will again note that I think I am hopeful around the willingness of people to talk and listen. What I've heard here in this session, as well as from other conversations across Asia Pacific, the pandemic started in this region. The technological solutions or technological responses to the pandemic started here. Some of the first violations or challenges with human rights took place here, but perhaps also the solutions to that balance will also happen in our region, thanks to the work of all of you.
네, 감사합니다. 사실 이제 각
Thank you very much for that. Yes, the internet landscape differs by countries, and the technological level differs, and all the circumstances vary. So we do struggle with privacy problems, as well as information, human rights, and so forth. But I think that these are some of the common challenges changes across countries. So thank you very much for that. We have one question. I think this question goes to Mr. Ko Hak-soo. So you talked about the human information, but then we don't have the right protective measures for that. So isn't that too premature? That was the question. Yes, thank you very much for that question. And as you know, the 3 Data Act was revised and went into effect this August. And well, now with that, we have the information of the infectious disease. So if this is only to protect personal information, we cannot collect such information. However, the precondition is that this is useful, and then where are we going to use this information? That is the question that precedes the law. And in that context, it is used for research purpose, and it will be used anonymously, but then what are the science information that will be required? And we say that the devil is in the details, so we have to look into the details, because otherwise it will cause more harm than good. So I think it's a golden opportunity to apply that in real life. Yes, we still have some way to go in terms of legal framework, but I hope that today's event serves as an opportunity to use this going forward to make further development.
Yes. Well, Professor Ko and Attorney So, thank you very much for your comments. I have a question. Well, concerning K-quarantine and the human rights, maintaining a balance between these two could be major and it could be minor. Well, what I meant by that was not that human rights can be major or could be minor. It was not that. Well, I know that all human rights matter. That's what I would like to share as my opinion. And Professor Ko mentioned about the judgment of the court. But before, the National Human Rights Commission discussed this agenda, and Dr. Che made a proposal concerning this, and not only because of COVID-19. Well, when I was working for a national health hospital, a multi-drug resistance was touched upon, and he solicited isolated treatment for a patient, but the patient did not want the treatment and he wanted to be discharged, but there was no binding regulations and laws for the hospital to keep the patient inside of the hospital. But I also found a case in the U.S. that there's a stipulation of health police, and in close cooperation with the administration, police was able to exert the relevant law in that case, and I really was envious of that approach of the U.S. So in case of COVID-19, there are some areas where quarantine experts cannot cannot hold the full accountability. So that's why I would like to suggest that the close partnership between administrative and legal entities so that we can have a more efficient quarantine measures. Well, thank you for your additional comments. We only have 3 minutes to go. Professor Oh? Yes, thank you very much, President Oh. Well, having this discussion is not to criticize quarantine experts on site who are not sparing any efforts. Well, for our country, this is the most risky days since the outbreak of COVID-19, and I assume that it is time for all of us to discuss how to expand the quarantine policies and measures. And after the crisis is finished, I do not think that we will have continued interest in this area, and that's why how to precisely design the quarantine policy should be discussed now. And in that sense, having updated several times the policy for disclosure of movement and flow was quite recommendable, and we should receive many varying opinions so that we can enhance the existing policy and measures. And the relevant stakeholders should be together, and today's discussion is part of that. I am not against the disclosure of movement and flow, but we need to be more human rights friendly. Well, we just heard about the confirmed cases of Itaewon, but you may criticize those people, but our awareness about the sexual minorities in Korean society, well, that made this situation because they might be exposed to high criticism about their sexual orientation. So that's why epidemiological research is not ended within that scope, but how to divulge information of individuals is closely related, and we need to have a comprehensive consideration of quarantine policies, and how to enhance the existing system should be discussed. And COVID-19 will last for a while, so we have to focus on the system enhancement. In 2015, when the MERS got spread it out, I also attended many societies and symposiums to raise awareness about information rights, but nobody responded vividly to my proposal, and people were not interested in that matter. But these days, the laws and acts on the protection of information rights and privacy rights, and I think that the fact that these agenda are considered as important discussion elements of the emergency, it justifies that we have advanced in terms of social rights. So COVID-19 is not something that could end in a moment. So in that sense, we need to further delve into the solutions for the protection of human rights. Thank you very much for keeping your seats until the end, and this brings us to the end of theme session 2. Thank you very much. 2020 Seoul Human Rights Conference. So we're now on the second day, and theme session 2, COVID-19 and information human rights, has just ended. In terms of those elements, how to make a balance between quarantine and the protection of the rights to information. Well, concerning that subject, I have come to think that there are many many homeworks and tasks to be done. Thank you very much. And our special thanks go to Mr. Chima and Professor Vale for attending until the last moment of the session. And thank you, moderator. And that rounds out the session 2. And the last session will be started in 30 minutes at 3:30. The theme session 3 will be about mental health and human rights. This is the last chance for our special event. Please don't forget to take a photo of yourself watching our conference online and upload it to your SNS account, and you may be selected to receive coffee coupon. Thank you.
Music always embraces an era. It holds the time, space, and scenery of the city that we love.
Seoul is a truly special city. This trail is an old railroad track that instead of being torn down, was completely reformed. The city has created a sense of ease and romance I had forgotten, and it surprises me every time I experience it.
You see? What another perfect reason to stay.
I moved to Seoul and now live and work here. I was very impressed with this culture that maintains original aspects while adding a new sense.
It's because empathy is what matters. People-centered values that prioritize the happiness of everyone are found across Seoul, where past traditions in the present coexist.
That warm feeling. Isn't that a great reason to live in Seoul?
I think Seoul is filled with more energy than any other city. Such energy becomes the possibilities of the future. Various attempts to connect individuals and businesses create new business opportunities, and it makes Seoul a city where creative investments are possible with advanced 5G technologies. Creative,
More dynamic,
more refreshing,
and more passionate city.
Seoul, a special city for you and me. I saw you.
여러분, 뭐 하고 계세요? 저랑 같이 서울시 인권 정책길로 산책하실래요? 서울시는 2012년 팀 단위가 아닌 과 단위의 인권 담당관을 신설하고 서울시 인권 기본조례를 제정한 것을 시작으로 전국 최초 시민인권보호관 제도 도입 운영, 인권위원회 구성 운영까지 시민의 인권 보호와 증진을 위해 제도적 기반 구축에 있어 선도적인 역할을 수행해오고 있어요. 과거에 있었던 잊어서는 안 되는 우리 인권 역사의 상징적인 공간들에 이렇게 도장을 꼭 찍어놓고 그 역사를 시민들과 함께 걸으며 기억하고 있죠. 그리고 현재 일어나선 안 되는 인권 침해를 예방하기 위해 철거 현장 인권 지킴이단이 시민들 곁을 지키고 있고요. 또 서울시 행정에서 인권 침해가 있었다고 판단되는 사건에 대해 시정 권고를 할 수 있는 시민인권침해구제위원회가 인권 침해로 인해 고통받는 시민의 목소리에 늘 귀 기울이고 있습니다. 든든한 시민인권보호관이 언제나 기다리고 있습니다. 서울시는 국내 최초로 시민이 인권 침해 및 차별 사건에 대한 결정 과정에 직접 참여할 수 있는 시민인권 배심원제를 도입하여 시민 스스로 인권을 지킬 수 있도록 돕고 있습니다. 서울시는 각 분야 인권 전문가들과 함께 앞으로도 시민의 인권을 위해 계속 걸어나가겠습니다. 서울시는 서울 인권 컨퍼런스를 통해 모든 시민의 인권이 바로 서는 행복한 사회를 꿈꾸며 인권 행정이 나아가는 방향을 모색합니다. 함께 누리고 포용하고 참여하는 인권특별시 서울.
A city filled with joy. A city dedicated to its people, where past traditions coexist with the present. A city filled with creative business opportunities. Seoul, a special city for you and me. I saw you.
Welcome back to the Seoul Human Rights Conference 2020. We will now begin the theme session 3 of day 2 of the conference. I hope you're enjoying the conference. We are gathered with human rights experts as well as local government officials and private groups to share ideas about how we can fight the pandemic. So we are now discussing various ways to achieve sustainable and universal human rights, and thank you very much for your participation and your feedback on YouTube. So I have a few housekeeping announcements to make before we officially begin session 3. The conference has moved online to prevent the spread of the virus, and you can enjoy the conference on YouTube. The conference is streamed live on YouTube. You can watch the conference on the Korean Seoul-si YouTube channel or the English Seoul City official YouTube channel. So please select the channel of your choice to join us. Also, the conference provides text and sign language interpreting for the underserved. I have one more housekeeping announcement to make. As we have moved the conference online, we are meeting you online. So please upload your questions on the YouTube chat box for the speakers to entertain your questions during the Q&A session. And we also ask you to participate in the Watch the Show live event. Take a photo of yourself watching the conference and upload it to your SNS using the hashtag for the event and share it on the official website. Then 100 viewers will be picked to win coffee coupons of Starbucks. Also, details of the conference are available on the official website, or you can just scan the QR code on the screen. And this studio was disinfected this morning and is operated safely in accordance with the quarantine guidelines. So please forgive us, the speakers, as well as myself, for keeping the masks on during the conference to observe the safety guidelines, although it will be difficult for you to follow the conference because of the mask. Now we will begin theme session 3, titled Mental Health and Human Rights. So now COVID-19 has raised many issues on the healthcare environment and economic environment, and human rights is also a sector that has been greatly affected by COVID-19, especially when it comes to the people with mental health conditions. So today in session 3 we will talk about the violation of human rights of those with mental health conditions. And we will have President Lee Young-moon who will moderate the session, and he is the President of National Center for Mental Health at the Ministry of Health and Welfare, and he was also the Director of Seoul Health Foundation. The floor is now yours. Thank you very much for that introduction. We will now begin theme session 3, titled Mental Health and Human Rights. My name is Lee Young-moon. Thank you very much for joining us online, and please stay with us until the end. And it is with great pleasure to moderate the session on mental health and human rights. We will hear 2 presentations and 4 discussions from 4 panelists. Let me first introduce the speakers. We have with us Medical Director Nam Yoon-young of the National Center for Mental Health at the Ministry of Health and Welfare, Editor-in-Chief Park Jong-un of MindPost, And next, moving on to the panelists, Director Shin Seok-chul of Songpa Mental Disabled Center for Peer Support. On his left, lab leader Kim Yang-gun and medical reporter at Cookie News Monster Lab.
공익임금법재단의 염형국
We have Mr. Yeom Hyung-guk, attorney at Human Rights Law Foundation.
김종옥 서울 장애인
Last but not least, we have with us Ms. Kim Jong-ok, leader of Seoul Parents Network for the People with Disabled. So we will now begin with the first presentation by the first presenter. Let me introduce the speaker. We have with us Nam Yoon-young.
He's the medical director of the National Center for Mental Health, the Ministry of Health and Welfare. And this year, the coronavirus got spread out in Cheongnam-do Hospital, and he has been serving for the mentally disabled in times of COVID-19 on site, and even for today at his institution, and positive confirmed mentally disabled patients are admitted to his hospital. So please, now the floor is yours. Thank you very much for the introduction, and thank you for inviting me to this meaningful conference. Well, I would like to share my experiences of having treated the mentally disabled and developmental disorder patients impacted by the COVID-19 and how to overcome the exclusion of these people in treatment, and what will be the direction for future enhancement in terms of readiness. Well, due to COVID-19, since this February until October, we have 6 outbreak cases of mass scale, and just right after editing this slide, we have 40 patients confirmed at other medical institutions, including Incheon and Wonju medical service institutions. All are public, and also we have cohort isolation ward. And once discharged from the hospital and once confirmed negative, these patients are admitted to our hospital, NHMC, National Center for Mental Health. And this is the current status of Cheongdo Hospital, taken from there right away. And on the upper row, these are taken just right after the outbreak of COVID-19. As you can see, they manage their lives on the floor, and the lunch boxes are not arranged. Many of the medical staffs got already left the place, and the cleaning and other basic services were not being provided. And pictures on the bottom row are taken after our arrival, and you can't imagine that these facilities are the same one. So they were able to get treated on these beds. And these are the pictures taken from the same hospital and from the other one in Daegu. The situation doesn't differ much. Well, social distancing is not respected amongst the patients, and they are exposed to the risk of being infected by the virus. But while treating patients,
200명 정도는
Well, up to now, around 200 patients are admitted directly to our hospital, National Center for Mental Health, and other patients that we in person treated and categorized and tested are around 400. And the biggest challenge that we had in treating those mentally disabled people and people suffering from developmental disorder was that it was extremely hard and difficult for them to get treated and for us to treat them as well. Well, in February 26th, while I was in Cheongdo protecting our patients, a news article from YTN covered this case, indicating that it is quite hard for mentally disabled patients to get treated when they got confirmed positive for COVID-19. Well, National Medical Center was one of the hospitals who received our patients with determination, but other hospitals rejected our patients, showing the fear of not being able to treat their own patients properly. And those fears were discovered in the beginning of COVID-19 outbreak in an extensive manner. And up to now, our patients are still having difficulties to get a referral to specialized hospitals. And that's why we take full charge of these mentally disabled and mental patients as well. And one of the tough cases is that severe mental illness. Patients with severe mental illness are excluded. And secondly, mild symptoms are approached in an ordinary manner, but patients with developmental disorder were not able to receive proper treatment on site. And also another issue was about people who continuously commit suicide resulting from psychopathic symptoms, and they need urgent protection and measures, but there are a limited number of medical institutions providing urgent care or urgent treatment with patients, so the access to care is not secured for those people. And we also found that the access to rehabilitation service of mental disabled quite difficult, and up to September and October, 90% and over of these institutions have been closed. So the mentally disabled were not able to access these services, and they didn't get any necessary help and support from these institutions. And partially, small-scale facilities or centers were under operation, but the number of these centers or facilities was quite low to accommodate all mentally disabled, and that's why they had to stay at home or at hospital. And this is the current status of service provided with the developmental disordered patients. And before COVID-19, we had 156 welfare centers for the disabled and 780 protection facilities for the disabled, but 90% of them were not open in July, and from November they are in operation partially, but these are only figures. If you visit these facilities in person, and you will discover that only a restricted service scope of services is provided. And also, the treatment related to developmental disorder is almost stopped because the medical services for patients with developmental disorder are mainly provided by public hospitals, which are now focusing their resources completely on the treatment of COVID-19. So we are suffering from the severe lack of medical staff. And this report was announced this April by the Association of the Parents of the Disabled. And the blue graph represents the time before COVID-19, and the orange accounts for the daily life patterns of now. And you can see that the outdoor activities have dropped significantly before and after COVID-19, and there are many difficulties for the disabled to get to let out their energies in an appropriate manner, and the communication, and also in managing their daily lives. They are having difficulties and challenges, and they are under great impact of the virus. But if you look at the details of it, well, what's most urgently needed is the provision of quarantine products, and also in a safe space individually, education and the care service should be provided. And we also received a request that the support service for outdoor activities is needed. And with the service for patients with developmental disorder stopped, we have seen many cases of suicides of the patient and their families, and that's why we see that more and more attentions are given to the access to the service for the disabled with developmental disorder. Well, we provide online lectures and courses in terms of urgent care with our students, but I also have my kids and I can see how it is going on, but I don't think it is effective. I am sorry to say this for those who have prepared for these online classes, but students with developmental disorder cannot use these urgent care services at classrooms, and only the programs for ordinary students are being operated. So our students with developmental disorder are excluded, and when it comes to online classes, the concentration is not easy, and it's also difficult to get focus on the class contents for a long time. And sometimes the criteria of education objective is quite high, so students find it difficult to follow it. And even with after-school activities, around 60% of the students are not able to use them because of the lack of information, and the complaints about online classes are growing. And the problems that we see from students who do not go to school, who cannot go to school, is that they feel numb, and their activity level is declining, and they gain weight, and the viewing hours of TV on online screens is also increasing, and they just stay at home, and this is the biggest problem. And that's why almost 50% of the parents request that the face-to-face classes should be continued, and 1/3 of the patients have requested to expand urgent care classes. Well, in a summary, our patients with severe mental illness and developmental disorder have two sufferings due to COVID-19. First, the depression and anxiety increased due to social distancing or social exclusion. And secondly, they are deprived of access to essential medical services or care of the local community, and also they are excluded from the benefits of local communities. Then, what's the reason of exclusion and isolation? Well, firstly, in relation with COVID-19, the biggest challenge that we have at our hospital is that our patients do not wear masks, and they do not follow the guidelines of quarantine and personal hygiene. community.
집단 생활을 하고 있고
And also, many are accustomed to collective life, and they have been admitted to the hospital for a long time, and their immune system doesn't work properly, and they have a high exposure risk to virus. And also, despite of all that, there are social prejudices and biases against mental illness and infectious disease, and these are dual branding. So endoscopic medical doctors say that they are used to infectious disease, but they get afraid of patients with mental illness, and the vice versa from psychological medical experts. So without the cooperation with big determination, exclusion is very often observed. And due to communication difficulties or cognitive matters, sometimes active treatment of infectious disease is hard. And one of the biggest challenges is that there is an absolute lack of hospitals that could treat the infectious disease of people with mental illness and developmental disorder. And secondly, the current status of accommodation is the problem. And most of hospital cases that I shared with you is that the executional plan are not ready with details, and that is why the institution is not being executed properly. And many cases of Daenam Hospital were introduced, and one specific patient got repeatedly referred to one hospital to another for more than 20 years and got dead after all. And recently, one of the admitted mentally disabled patient got murdered his doctor at Busan. And second challenge that we have is a limited access to essential medical service. And this is not only related to COVID-19, but when there's an emergency case, mentally disabled show a lot more difficulties in receiving treatments, and that's why emergency medical centers in regions have difficulties, a lot more difficulties in actively treating those patients, and it is directly associated with the evaluation process of the hospitals, and they got more and more hesitant to receive those patients. And also, it is extremely difficult to evaluate the physical condition of the patient at the mental health institutions, and when there are comorbidities and other infectious diseases observed from the patient, and there's excessive measures of closing the hospital to prevent collective infection, and that is why they get more and more passive to receive and treat these patients. And thirdly, we have an issue of environment. As shown earlier in the slide, medical intervention and burden for treatment are the reasons, but also inappropriate condition or environment for treatment and quarantine is the essential factor that we need to address for improvement. And one another reason is bias and branding. Before our hospital got established, got constructed, I took these pictures. Well, at the front gate of our hospital, local residents had a demonstration objecting against the construction of the hospital, chanting and shouting that we had to go back to you have to go back to your home place. And this was covered by the media aggravating and recognizing the social bias against mentally ill people. And also we got to have a fear of being excluded and being the subject of social bias. But that turned into this, and many residents in surrounding areas use actively these hospitals, and they even are in the same space as our patients, having meals and coffee together. So partially branding issue is solved, but still the mentally ill become easily the subject of hatred and exclusion. And one another problem is the lack of treatment facilities. In 30-ish hospitals nationwide, a nation-designated treatment beds are 535. We have 198 negative pressure wards and 337 ordinary beds. Going through COVID-19, we created 4 exclusive beds for the treatment of the people with developmental disorder or mental illness due to COVID-19. And since from this December till March next year, we will be establishing relevant treatment facilities. And one another issue is to get rid of discrimination against the medical coverage, medical insurance coverage. Well, regardless of the types of mental illness, they tend to have difficulties in finding jobs, and by receiving high-cost services, medical services, and their socio-economic level gets decreasing. But their insurance coverage is quite low, around 80% of ordinary insurance coverage, and then medical care for the admittance is around 60%, and that is why there's a certain gap of quality level between medical services, and our patients tend to get admitted to the hospital in long term. So the malicious circle repeats on and on. And as mentioned earlier in a summary, the level of facilities is the one of 1990s or less than that. And the current medical system focuses on admittance and isolation, and that's even restricted by the laws and regulations, and the lack of medical staffs, and also the medical care coverage is low compared to other cases, and the necessary service is not properly delivered. That's why the institution is failed, and this malicious circle is on and on. And this problem was recognized since the 1990s and 80s when I was a student, but this has not been solved yet. So then what should we do? Let me touch upon that briefly. First, we need to change our mindset, point of views against the people with mental illness and developmental disorder. They just get treatment, and they should get protection from the society, and they should not be excluded or isolated. They have the dignity, and they have the right to receive services when necessary. And secondly, we need a service paradigm for this. They are part of our local communities. They are not different from us, and that's why they are not supposed to receive different services. That paradigm should change, and we need to have more interest in their independence, including job, employment, and accommodation. And we should change our minds. The relevant rules and regulations should be be redressed to follow the new mindset of 21st century for the people with the mental illness and the developmental disorder. Then what should he do in more details? Well, concerning the support for independence of local communities and service delivery system, I have touched upon that matter. And public health and public welfare service should be redressed, and also the focus should be laid on the subject person or the subject patient. To that end,
도움이 필요한 분들이다. 가끔씩 도움이
we say that these people are in need of help or are in need of service, and we should share this recognition altogether to create an empathy for them. And secondly, we should lead some activities to relieve social biases against the mental illness, and marketing activities are needed as well. And thirdly, raising awareness through a social system about mental disorder and developmental disorder, because we do not know too much. And also, I would like to emphasize that we need to improve infrastructure. Well, but infrastructure has been addressed a lot, but we haven't enoughly talked about the issues of staff members who provide a service within that infrastructure. Well, good people should get treated well so that they could provide quality services. Well, we have to change our minds that the quality doesn't matter because the service is free of charge, but we need to train the best talents so that we can provide proper services with people with mental and developmental disorder. And the trauma experience is one of the main services that we provide, and we need to detail our services to treat those symptoms. Thank you. Thank you. Well, we do not have much time, so it's unfortunate that we do not have enough time to listen to his presentation more fully. Overall, he just made his opinions on how to improve the social services for the mentally disabled, including change of minds and respect to the rights of those people. Well, treatments and other ways are a lot discussed, but the change of minds and paradigm shift, these are two important factors. Thank you very much.
Now moving on to the second speaker, we have with us Mr. Park Jong-un, Editor-in-Chief of MindPost, which is an online media. And he's been serving as editor-in-chief for 3 years, and he writes articles based on his own experience and to create a better world. And with the outbreak of COVID-19, there were many death cases of the people with mental health conditions, so I think he will talk more about that as well. Yes. Good afternoon. My name is Park Jong-un from MindPost. In June 2018, MindPost was first founded, and the people working in MindPost have mental health conditions. So before we founded the company in 2018, we used to get together every week for about 3 weeks to learn and study about how to write articles, how to cover different topics, and how to take photos. And at the time, we did not know what the outcome would be, but then it led to a success, and it's been about 2 years and 6 months since we founded MindPost. And our catchphrase is do not speak about us without leaving us out. So we try to talk about the social system as well as the nation by raising a voice of the people with mental health conditions. So we are advocates of those with mental health conditions, and in February there was the Cheongdo Daenam Hospital, as well as the one in Gyeongbok, not Daegu, where the first patient with mental health condition died of COVID-19. That person had been admitted to the hospital for 25 years. At the time of death, the person only weighed for 45 kilograms, and I wasn't able to visit the hospital myself, but then Cheongdo Daenam Hospital is out of nowhere, and then you have like a vast field just in front of the hospital, and it's a small village. So it was hard to imagine how it would be like for a patient with mental health condition to be confined in such an institution where you can't access anything. I mean, people with mental health conditions are not criminals, and why confine the people with mental health conditions in such institutions? So why are we excluded? Why are we discriminated? Why are we isolated from the society? So we keep asking those questions. So we have to rely on the reasoning, which was the philosophy of the 16th and 17th century, and mentally ill people have become someone to shun, someone to avoid, someone unpredictable as we moved on to the modern times. So instead of voicing up, they are subject to different diseases which brand these people, and they are viewed by how they are defined by the medical institutions. But then they should have a voice, they should be able to speak up. So that's what I would like to mention. So I would like to say a little bit more about the media's stigmatizing attitude toward mental disability. And the media tends to view those with mental health conditions as criminals and mental health conditions as crimes. And I'm sure they've never met these people. And because of that, whenever we have some problems arising from those with mental disorders, people tend to panic and reinforce the negative attitude towards these people. And that's how journalists react to the incidents caused by those with mental disorders. And with that, they have spread out fear among the general public. So to be liberated as a human, I think we need to have a more inclusive view of these groups of people. Now we have the media, and we also have the mental institutions that I believe frame the patients with mental health conditions as those we should avoid. So today I would like to talk about that frame and how the media, especially the mainstream media, looking at the people with mental disability.
우리 세계에는
So
이렇게 정신장애인들을 조롱을 합니다.
patients with mental health disorders are mocked by people. They are viewed as persons with mental disorder that only eat, take medicine, and sleep, socially worthless beings, threat to good citizens. And there's this logic of hate and the logic of exclusion, and the media replicates the language used by the powerful groups without raising questions. So I would like to talk a little bit about Carvin.
20세기 초에 그런 글을 씁니다.
In the early 20th century, so John Calvin talks about
사회적으로
the people worthless of living, and he talks about the mentally ill patients, and he goes on to say that the society has no responsibility to take care of these people. And as Germany moved into fascism in the 1930s, this ideology was reinforced. So what happened back then was that there was this logic of the racial superiority. And of course, even before that, the people with mental health conditions were excluded from the society. But then, not to the extent that these groups should be killed, they're worthless, and they're not needed to our society. And this ideology, I believe, still remains with us in Korea. Then, what are journalists? What do they do? And as you know, they have to keep raising questions. And at the same time, given the community that we live in, they have to keep asking questions whether our society is just. And if not, journalists have to voice up. And at the same time, explore social agenda. And I believe that they have to speak for the mentally ill people, the minorities, as well as the vulnerable. So they have to keep asking questions. They have to remain suspicious, and they have to serve as a watchdog. I believe that is the responsibility of the journalists. Then what are the senses of ethics required of journalists by the mentally ill people? They have to have the power to doubt, which justifies their existence, and they have to raise questions over the absurdity in our society, and they cannot simply negate what does not work for them. They have to keep asking questions about the irrationalities. And until now, no one has been playing that role. For instance, recently, I'm sure that you heard of Jo Joo-bin, this criminal that sexually exploited women and created content on sexual exploitation. And there were many women who fell victim for that. But let's say that if this had happened 20 or 30 years ago, I'm sure that most of the media would have just used the terminology that these were just pornography. However, as the society changed,
그것이 강해지면서
And with feminism and gender conscious becoming part of our everyday life, now those content were viewed as crime.
폭행하고 나서 폭행이 나쁘니까 나쁘다 윤리적으로 나쁘다고 얘기하는 이중 무선을 낳습니다.
So the logic is that the society keeps saying that the society should be considerate of the people with mental disorder, but then at the same time talk about the need for control. But then this leads to a double contradiction. So let's say we keep saying there was a mentally disordered person who committed a crime or committed an incident and killed a person, but at the same time they keep saying that we need to control those people, but at the same time be considerate of those people. And I think that leads to a double contradiction. So I think there are a few angles that the media take when interpreting the people with mental health conditions. For instance, they link them to crime. So let's say that, there was this case when a mentally ill person committed a crime or so. Then the journalist, out of fear, would write an article that sort of spreads the fear and disseminates fear. Then most of the consumers and the community will reinforce such prejudice, and the outcome and the conclusion would be that those with mental health conditions need to be confined in institutions. So sometimes the physically disabled people, they climb the Mount Everest. Sometimes they would run the marathon, or sometimes they would even run in a triathlon, and that itself can be covered by a journalist because it's about overcoming the physical disability, and they become the role model for many people. However, when it comes to the mentally ill people, the values that they have are already damaged. So journalists do not talk about what these people are trying to overcome. The mentally ill persons are only painted and pictured as criminals, and journalists emphasize on the danger of the mentally ill people, and they tend to link these people with cruelty and as people that are unpredictable, and that is because the journalists have fear towards the people with mental health disorder. And that translates into the anxiety in society. So let us look at some examples. First of all, linking to crime. This article was about this woman who went for wild vegetables in Inde, and she was found murdered. And the man in his 20s living nearby was brought into custody. But then here, what the media said that, this person has no history of receiving treatment for mental illness. Why include such a sentence in the article? It has nothing to do with what actually happened. So there was no need for the journalist to link mental illness to this incident. However, by adding this sentence, the journalist keeps reinforcing the prejudice. So let's say that a person with no mental disorder stole bread. Would that even be covered by a news? No. But then if a person with mental disorder steals a bubble gum, then that would be covered. And let's say that you have this person with no mental disorder playing around, fooling around with a toy gun. That would not even be covered by the media. However, it would be if that person had mental health conditions.
진단명을 자의적으로 했어야 합니다.
And also what happens is that the journalists make arbitrary interpretation of the diseases. Out of the 15 illness that fall under the disability, 13 fall under physical disability and 2 under mental health conditions. Now we use different terminology such as mental health conditions as well as intellectual disability and sometimes developmental disability. And what happens is that the journalists make arbitrary interpretation of such illnesses. So they tend to confuse different terminology such as autism as well as depression and schizophrenia. So they're not interested in the specific categories of the illness. What they do, they would just categorize it under mental illness and use that term in their articles.
많이 이렇게 뭐라 그럴까 굉장히 좀 고통스러울 정도의 어떤 해석.
And sometimes they use brutal expressions about the persons with mental health conditions.
근데 저혈증 환자가
there is this article about a schizophrenic patient who killed his father by hitting him. And this graphic picture becomes even more enhanced by using the word schizophrenic and mentally ill. And a lot of journalists, they tend to write articles based on speculation, so with no fact, and it's not grounded. And that's how the mentally ill people have been defined for a very long time. And in November, the National Human Rights Committee released an announcement.
동의 없이 피의자의 정신병력을 공개할 수 없다라는 어떤 근거를 내렸습니다. 이렇게 되면은
it was that the police can no longer disclose the mental health history of the criminals without the consent of the criminals. And the same applies for the journalists as well. So journalists have no right to disclose the mental health conditions of the criminals.
하나 있습니다. 아버지 통기 사례. 그렇죠. 끊임없이 정신장애는 이렇게.
So there is one more example of this person who killed his father for fear of being scolded. And up to now, the media has been framing these people as criminals. But we have to keep fighting against such representation of the persons with mental health conditions. And we have to keep challenging the distorted perspective of those with power. And that's what MindPost is doing. And the persons with mental health conditions can choose their own way of life in a humane manner to be part of our community. Thank you very much for your time. Thank you. I hope you had enough time to present. Thank you very much for that presentation. So you presented a few cases that were released on the media and talked about what was wrong with such articles. So thank you very much for that. So we have 4 panelists with us today. So we will hear the feedback from the panelists and then move on to the Q&A session.
So, okay, all right, we'll follow that order.
염영국 변호사부터 먼저 하도록 하겠습니다.
And Attorney Yamhyung-guk will open up this panel discussion session.
있으시죠? 우리 아름다운 재단.
Well, he is a famous attorney
인권법 재단이라.
because he is from Human Rights Law Foundation.
프로노보 지원센터장도.
And he also served as the center for Seoul Pronovo Center. And he is the member of Seoul Human Rights Commission. And he also served as a human rights member of the Korean Attorney Association. Well, actually, I was the third, but I am suddenly given the chance to make my comments. So I'm a bit perplexed. But anyways, well, my statement is shared a bit late. So in the studio, everybody can see my PowerPoint slides, but not available for the viewers joined on YouTube channel. So apology for that. We have just listened to 2 presentations of Dr. Nam Yun-young and Editor-in-Chief Park Jong-won, and let me make a shorter comment on those 2 presentations. Well, concerning the mental health and human rights in the spread of COVID-19, I understand that how hard it is to bear this situation, and to prevent the spread of COVID-19, we need to get ourselves shunned away from concentration and permeation.
그런데 이제 전국의 많은 정신병원, 정신요양시설,
So we have to really keep the social distancing, and proximity is not a good idea. So at the same time, we need to disinfect the areas that we are in, and also keep ventilating at the same time. We have to make sure that the mental hospitals, as well as the care facilities and the facilities for the disabled, are not too clustered, and make sure that they are not too crowded. But that's not the reality, because we have about 10 patients in one single room, and they have to stay in close contact to each other. So as I mentioned, we should avoid proximity as well as close contact and so forth. But that is not the case in the institutions that we are seeing right now. So for instance, we have Cheongdo Daenam Hospital as well as other institutions across the country, and that is why we are seeing a surge of COVID-19 in those institutions.
So it will not be easy for us to be free from the risk of new types of infectious disease. So to prevent the spread of new viruses, which will be severer than COVID-19, then we have to have foundational solutions to that. So not only by changing the environment within the facilities, but we need to orient ourselves to the deinstitutional policies. And recently, the COVID is getting severer globally, and the 87% of the mortality rate has been reported from the people at facilities, which was quite shocking. And based on this report, and there's a human rights association called Network for the Disabled Independence, and that network has recognized that the COVID-19 pandemic situation falls into the category of humanitarian support for the emergency, according to the 11th article, and they have requested to exert the deinstitutional measures for the disabled. And a nationwide deinstitution and hospitalization are actively propelled by human rights activists, and this will be proposed to the National Assembly of the 21st Union, and this is a kind of current trend that we can't deny, and our society of mental health should try to change the customs and existing measures. And in COVID-19, access to services for the mental patients and the people with developmental disorders is decreasing sharply, and services for those people should be provided depending on regions, and minimal face-to-face education and face-to-face service should also be offered to these patients.
다음으로 이제 의료 수가의 문제입니다.
And next, the medical care.
선생님께서도 지적했었듯이
Well, Professor Nam has also mentioned about this, the discrimination of medical fee or medical charge. Well, this has been addressed a long time, but not enhanced. The medical fee for mental illness is categorized into acute and chronic, and also visits and admittance, and we should categorize them into two so that we can respond to the establishment of the long-term admittance structure, and also the discrimination or the difference between health insurance and medical care fee, and that should be broadly enhanced so that we can guarantee the improvement of medical service and its access to. And let me now make some comments on the presentation of Editor-in-Chief Park Jong-un. And many of citizens have low awareness of mental patients, and mainly information is received through the media and mass media as well. But as pointed out earlier, many media makes inappropriate articles about mental patients, and the social bias has been reinforced in the long term, and the damage of this media coverage is quite significant against the mental patients, because patients with mental illness are viewed as potential criminals, and many relevant institutions and activists have been advocating the rights for those people. But once this kind of media coverage is communicated, then their efforts get in vain. And recently in 2018, the Ministry of Health and Well-being and the Suicide Prevention Center and Korean Journalists Association have jointly declared and enacted the guidelines about the media coverage against suicide, and that made some substantial results of declining number of suicide-related articles. And this type of guideline should also be established for the patients with mental illness. And concerning the stipulation of the article guidelines, well, I would like ask Ministry of Health and Well-being and National Mental Health Center and other relevant institutions and Korean Journalists Associations to form a task force team to have a rules and principles for the media coverage. As far as I know, there has been some efforts for this, but this was not well merged with the external stakeholders. So Mr. Park has made some recommendations. So I wish that those proposals of Mr. Park could serve as good document foundation. And these days, the infrastructures related with human rights are focused on the institution. So if we can have a guideline in media coverage, and that will help and contribute to the betterment of human rights for the mental patients. Thank you very much. And he has made his comments on two different presentations in terms of human rights for the mental patients, and in particular with National Mental Health Center. He just proposed to put forward some guidelines for the media coverage, and I strongly agree with that idea. And Mr. Park has not fully made his comments and presentations due to the lack of time, but some articles about the disabled and their characteristics. I think he tried to mention about that. Well, I hope that the time would allow for that comment. And the second discussant.
Now moving on to Mr. Shin Seok-chul, who is Center Director of Songpa Medical Disabled Center for Peer Support. And I'm sure that not many people are aware of this center, but I hope to learn more about it. Yes, good afternoon. My name is Shin Seok-chul. I'm the Director of Songpa Mental Disabled Center for Peer Support. Thank you very much for having me to talk about what is happening at the center level. Thank you very much, President Lee Young-moon, for inviting me here. So I would like to talk more about what we need to do to respect the lives and the human rights of the people in the communities. So that would be the topic of my talk today. So the people with mental health conditions should be respected, and they should have their dignity respected. And at the same time, that would include that the institution is guaranteed, and that we also promote their human rights. And I hope that the persons with mental health conditions can be respected in the community, and I would like to make a few proposals for that. First of all, Now, we have to include persons with mental health conditions. Now we call them as people with disability. However, when it comes to the welfare delivery system for the disabled people, a lot of mental health persons with mental health conditions are excluded from those benefits. And at the same time, we have this act on mental health conditions. However, we cannot just rely on a few guidelines and protocols to claim that we understand everything about the mentally ill people, but that is the reality. So we have to really examine the current status. We currently have one single department in Seoul Metropolitan government dedicated to the persons with mental health conditions. But then we have to really have more teams working for this to be able to deliver the services better for the people with mental health conditions. At the same time, we have to decide what services to deliver to the mentally ill people based on the demand. For instance, as of 2020, a total of 269.9 was allocated for the people with disability, but then only 752.7 billion is used for the support of the disabled people. And when it comes to mentally ill people, the budget is only 59 billion. So I believe that we need to improve both the quality and quantity of the programs for the mentally ill people. At the same time, I don't think that persons with mental health conditions only can be categorized under depending on what types of treatment they receive. So we have to ensure that they are respected their dignity and can enjoy a quality of life. And that is why we have to be in line with Article 13 of the ordinance of the current act on the people with mental disability. Secondly, we also need to support the self-sufficiency of the people with mental disorder. I think we need to change the paradigm. Currently, we only apply the lens of the acts that we have under the Mental Disorder Act, but I think we need to shift the paradigm into a self-sufficiency paradigm. And I'm sure that you know the difference between rehabilitation paradigm and self-sufficiency paradigm. So we need to move towards a self-reliant paradigm. Next, I would like to talk about the regulations under the Self-Sufficiency Livelihood Act, Article 13. And there are many acts that fall under the welfare service provision under this act. However, we don't see any details stipulated in the act. So if we were to comply with the existing law, there are many loopholes, which is why we need to revise the act to support the people with mental disorders so that they can stand on their own 2 feet. Next, I would like to talk about the regulations for the shelter for the mentally ill people. And we don't have enough centers or shelters where these people can rest other than their own homes or hospitals. So this is why I propose the building and establishment of such shelters for the people with mental disorder. And when the government come up with budget, they talk a lot about the legal ground. Anyway, I think that we have to look into the Article 2 and 4 of the self-sufficiency Sufficiency Act as well as Article 8 of the Mentally Disabled People's Self-Sufficiency Center. And I think those regulations can serve as the legal framework for the budget. So I think we can do more. And Seoul City currently operates 2 centers for the mentally ill patients. I think we should do more of that. Now, since I don't have enough time, I will be quick. And fourth, I would like to talk about the establishment of a welfare center in Seoul for the mentally ill patients. Currently, these patients can only receive limited services from the local community, and that is a reality. So we need to have the Seoul City build a welfare center for the mentally ill people so that they can really realize self-sufficiency. So we need a support framework for that. So I would like to propose a few ideas. So far, we've had many programs to build centers for the mentally ill patients. However, they did not really engage the persons with mental disorder in the process. Of course, I'm sure that there are some centers that did engage the people. However, in overall, I think we need to provide services that can meet the individual demands of the people. That is because most of the people who actually use these facilities, they have various needs and demands that are unmet because the programs are not customized for the mentally ill people. And secondly, we need to deliver employment services for the mentally ill patients. Currently, they have limited opportunity for employment, and out of the 15 disability types, my understanding is that those with mental health conditions are the least employed. I think it's about 11.7%, and most of the people with disability are eligible for the services provided by the rehabilitation centers. However, now the mentally ill patients have to compete with the non-disabled people for jobs, and that is unfair. So we need to enhance the employment services. Next, we need to form a partnership with the different centers for the people with mental health conditions to deliver better services. So now the welfare centers not only hire experts, but it is my understanding that they also train the people who will work for the centers. Well, to be honest, I have my own share of criticism for that. But anyway, because the reason is because so far they've trained people, but that did not lead to job creation. So I think we must have a clause that mandates the care providing for the people with mentally ill people. So I would like to say this as I close my talk. So 200 years ago, when people shouted for the liberation of the slaves, those people were deemed as crazy people. And when you demanded that women should vote, they were imprisoned. And 50 years ago, when you fought for your country's independence, then you were deemed as a terrorist. So in the short term, this may look like it is impossible. However, in the long term, our society keeps growing and maturing. So I would like to ask all of you to join forces together so that we can achieve de-institution and a humane life and a quality of life for the people with mental health conditions. Thank you very much. Yes, thank you for that. You talked from the perspective of the Mental Disabled Center for Peer Support, and
서비스를 제공.
As of now, the types of service delivery is actually taking the perspective of the provider, not the user. So you mentioned that as well. And yes, we also have our own peer support center, and it is very important to train people who can really provide quality of services.
Thank you. Moving on to the next discussant, we would like to invite reporter Kim Yang-gyu, who's running Cookie News Monster Lab, and I got awarded recently by the Civil Association of Democracy. And this is quite an honor for a reporter to get awarded by that association. And he also got awarded for scientific journalist. And would like to ask for his comment on this. Good afternoon. I am Kim Yang-gyun from Cookie News Monster Lab, and I'm a medical reporter. And I would like to share my stories of the field. And before I kick off in earnest, I would like to introduce a documentary produced by Monster Lab. And as introduced just before, it's the part of the documentary series of You and Me, and I got edited for the part of the mentally disabled.
매우 적었죠. 한 달에 8만 원 받다가 내가 작업한 걸 내가 걷어가지고 그거를 갖다가 박스에다 집어넣는 것까지 다 했거든요. 그래서 2만 원을 더 준 거예요. 그래서 10만 원.
직업 선택의 제한은 그들의 삶을 어렵게 만듭니다. 자립이 어려워지면 고립될 수밖에 없기 때문입니다.
정신건강복지법상의 정신질환자를 자격 시험을 못 보게 하고 면허를 못 따게 하고 채용해서 제한을 하고 이런 사례들이 지금 굉장히 많기 때문에
과거보다는 그 정신장애에 대한 인권의 문제가 향상되었다고는 봅니다만은 아직까지 새로운 직업을 갖는다든지 혹은 새로운 사회 구성원으로서 경쟁력 있는 위치에 가기 위해는 아직까지 턱없이 부족합니다.
정신장애인은 분리, 배제해야 한다. 그리고 이것이 가능한 시스템, 이것은 인간성의 거세라고 말할 수 있지 않을까요?
예, 그 영상 잘 보셨나요?
Hope you enjoyed the documentary film. The woman in the video has mental illness, and she made up her mind hard to get filmed, and she is now helping other mental patients through various associations related with mental illness. When I meet them, I ask this question: how much they earn, and the amount is always quite low. And the woman in the film said that she earns around 1 million won per month, and she was quite proud of that. But I felt quite frustrated from hearing that answer. I can't generalize these people, but during the past years, doing researches on mental patients, the quality works or the quality jobs that we call are quite inaccessible to these people. So they mainly work as part-timers at cafe or at other unstable employment spaces, and the payment is quite low, and those salaries, those money are just used for their basic living, so they can't even imagine about their pension. And the working condition is being aggravated due to COVID-19, and the most excluded class is mental patients because they are low qualified and not skillful. And the woman in the film is the one of the exemplary case in a good way. I mean, because she has a place to stay in and she has her own job. And this is quite dangerous because without independence, they are exposed to exclusion and isolation, and that results in negative results. So making a documentary, we had repetitive interviews, but we edited some parts because it was too shocking. And she just plainly said that she got abused physically by the medical institutions and she got out of the hospital, but she was claimed to be the offendant. So that's why she tried to get suicide several times. But listening to her story, I decided not to insert that story into the video because it was too shocking, but I was also at the same time curious to know why the life for mental patients should be that harsh. And also, I met some mental patients physically violated at medical institutions, and I got an interview of a policeman, and one of the high-level management of the police station told me that sometimes we can hit those mental patients when they are not obeying. Well, I am not telling you that every policeman is like that, but that shows indirectly that the perspective that the ordinary people have against mental patients. Well, we do not have much leeway in the spread of COVID-19, and we are afraid, thinking that we can also be victims or we can be infected. So that's why we do not have generosity to think about human rights for the people with mental illness. After the incident of the death of a psychiatrist, many events were held and hearings, forums were held at the National Assembly, but I've never heard that even one mental patient was attending those forums and events. And it was summertime when there was a demonstration of mental patients in front of the National Assembly, and they claimed that how can people discuss the way of excluding or isolating mental patients without the participation or engagement of us? And after the interview, it was in the middle of summer, and it was so hot, and some bottled waters were on the floor, and one of the mental patients saw me, and he approached me, handing me over that bottled water, and thanked me. And he said that nobody came there, even if 1,000 journalists were attending those forums at the National Assembly. And I felt it, that he was so desperate because I held his hand, receiving the bottled water that he was giving to me. Well, you may say that I am too negative, but I also think that changes can be made. Well, we should think about our prejudices or thoughts. Once our thoughts change, then public opinion is formed, and that will make impact on the society. Then who can make the impact? The media. As Mr. Park has just mentioned, that the main media is neglecting one point. Even the experts of public health neglect this point. Well, many of journalists and media compare mental patients and and the users of hospitals, and they seem to be biased to the ordinary users. I don't know why. Maybe users are powerful while mental patients are not. Then how can we change the situation? Do we have to make policies, and do we have to make paradigm shifts, mindset changes? I don't think this is a tough task. The role of all of you is important, and the viewers of this conference should play their roles as well. It's not tough, it's not difficult. You can criticize the discriminatory articles or articles making hatred against the mental patients, and you can upload your comments as replies, or you can also criticize those articles through your individual SNS account, excluding the socially vulnerable to get a high view that should be regarded as shame. And like that, we can change public opinion. And once public opinion and general discussions are made for the sake of mental patients, then we can create a proper environment for them. The last comment that I would like to make is that the strong doesn't help the weak. The weak is always helped by the weak. We all are workers. We all are the weak. So we need to take more care of the human rights of the mental patient. Thank you very much.
몬스터랩에 저도 잠깐 제 화면에 나왔습니다만.
Well, thank you very much.
몰랐습니다. 아주 너무
Well, Monster Lab, I didn't know that you got awarded for that. And thank you and congratulations. And listening to your comments, well, it reminds me of the proposal made by Mr. Park and Attorney Yan. And all of you recommend to do media movement. And as the president of National Center, I am greatly motivated to join forces with you. And through this conference, we need to kick off our actions all together to define the criteria of the media coverage for the mentally disabled.
Now moving on to the last discussant, we talked a lot about schizophrenia as well as other different types of mental health conditions, and the same goes for the those suffering from developmental conditions. And because of that, we have invited Ms. Kim Jong-ok to join us. She is the leader of Seoul Parents Network for the people with disability. And we have this center to support the families with a disabled person. And she is also editor of 한겨레 opinion piece called Window to Life, and she also wrote some books such as Confucius Takes the Subway, John Tzu Gets Cheated, and so forth. The floor is yours. Yes, thank you very much. And I wasn't expecting you to introduce my books, but thank you very much for that. My name is Kim Jong-ok. Thank you for having me at this prestigious conference. So when I heard that mental health was the topic of this session, I was a little bit surprised. And well, thank you very much, Director Nam Yoon-young, for the detailed presentation and your insight into the people with mental health conditions as well as developmental disorders. And I have a child that suffers from developmental condition. So I would like to tell you a story from my perspective, and also at the same time the difficulty that we are faced with due to COVID-19. So I wasn't expecting to have the mask on for the entire year. And when COVID-19 first broke out, parents that have children with developmental conditions thought that by staying home, not going outside, being stuck at home, then one day COVID-19 will be behind us. So we stayed home for many months. But then in the process, we learned that the difficulty is not just experienced by those with mental health conditions, but also the larger population is also feeling the pain. So we tried to endure the pain because we thought it was unfair for us to voice out the difficulty that we were experiencing. But at the end of the day, the vulnerable is hit harder, and when we don't speak up, then we are even more isolated. Now we have to ask questions about the fundamental health of Korea's welfare system. So there was a presentation and comment about the health conditions of those confined in institutions, and those in institutions tend to be cross-infected, and they tend to become the severely ill patients. And of course, as a parent with a child with developmental conditions, I was sort of expecting such outcome. However, now I see a very dark feature. So those frail people in institutions, and while looking at them, we felt hopeless. And COVID-19 has caused a social isolation, and the social isolation is very similar to the isolation that those with developmental conditions suffer in their everyday life. So these patients are isolated and alienated even in their daily life, even without the pandemic. So we talk a lot about the situations before and after the pandemic, because the health conditions deteriorated among the patients with developmental conditions. So according to a statistics, about 87% of those suffering from developmental disability experienced a decline in health conditions because they suffer from isolation and depression. And there was this mother with a child of developmental disorder that killed herself and her child as well. And that was not just a single case. There were two cases like that. And as a family with a child with developmental disorder, I actually feel the pain. And in the fall, there were 3 cases of patients with developmental disorders who jumped out the window and fell to death. And we were extremely shocked by those events. And as I mentioned, isolation is not new to the patients with developmental disorders. However, we have to tell them that what's going on right now in society, and that this can threaten their safety. And when you can no longer enjoy the public space that you used to enjoy, and also the human touch that you can no longer enjoy because of the pandemic, then that can lead to further isolation, and it can deprive the enjoyment of such freedom among the people with developmental conditions. So we feel the pain because we are peers of the patients with developmental conditions, and I think it was the same for other parents, but I could not sleep when I saw the news that there was a patient with developmental condition who jumped out the window, and I was afraid to even imagine what had happened to that person. So we did not spend enough time to look into the pain of these patients, and we have to understand that the communal space as well as the public space that the patients with developmental conditions enjoyed before was the only channel for these patients to breathe out. So we have to really give them back such right. And of course, now because of the self-quarantine as well as self-treatment, we are facing further difficulty. Of course, we do have manuals and protocols, but it's really posing much challenges to all of us. So we need to have a strong public system that creates a public space for those with mental health conditions. And we need to have good neighbors in the local community to really check in on those people with mental health conditions and to address their difficulty. Of course, that is also important, but at the same time, we also need a public system that facilitates such a interaction, and that's what we want to experience in our everyday life. So, listening to the many presentations and talks, I see the inequality as well as unfair treatment and exclusion and discrimination that's often found in our society. And I think we should join forces to create a neighborhood where we care for each other. Thank you very much for the great presentations and also the talks. Thank you very much. With that, I would like to wrap up my talk. Thank you very much for that. Yes, thank you very much. So you talked about the public space. At the same time, the time that they spend in those public space. You mentioned the importance of that for the people with mental health conditions.
Well, we've listened to all four discussants, and on YouTube, we do not have any particular questions uploaded, so let me ask questions to two presenters. Mr. Parker, would you please go first?
So you were not able to finish your presentation before because you were pressed for time, but I'm sure that you want to propose some of the guidelines for the media, and I mentioned that there should be some guidelines that the press should follow. So would you like to mention a few words about that? Yes. Now we have the National Human Rights Committee and Mindpost, and we also have the Public Legal Center hosting some of the events, and at the same time we are co-carrying out some of the activities. So we have, of course, the media release protocol that Mind Post unveiled, and there's one from the National Mental Health Center and others as well, but we have a long way to go.
아마 여러 곳에서 목소리를 내는 것보다는
Well,
함께 목소리를 내더라도
rather than having diverse voices from different areas, but I think it is always better to have a concerted voice with the principles and contents. And the Association of the Suicide Prevention is formed, and we have been making our activities with those associations in the past. So if it could use some resources of different entities, would be appreciated. And Attorney Yam can form that kind of movement, I hope. And Mr. Nam, please. Do you want to make further comments? Well, I try to point out a specific phenomenon and the inequality of the service, but what's most important from my perspective is to see how we could live together as members of the society, and how we can be respected by one another, and how we can coexist. And that should be a bigger discourse. That's what I felt. And as experts, we cannot solve this by ourselves. We should make existential elements of human, and the socio-cultural aspects should get more mature. And that's why I came to think, I just keep returning to the idea of having a solidarity. And I want to see joint forces of every people related to the human rights of the disabled. Well, we should join forces, and we should make propelling motor to move the society. If we keep asking for the support from the nation and from municipalities, and that should be the restriction to us. So through this human rights conference, I wish that we could make a turning point, and I would like to get engaged in that movement as one of the members. Well, thank you very much. It was last year in 2019 that I attended the Seoul Human Rights Conference, and this is the second year for me too as well. But amongst the 17 municipalities, there are Seoul is the biggest city holding a human rights conference, having formed a human rights commission within it. Seoul Metropolitan Government is the one and only municipality. And thank you for your effort. And the National Human Rights Commission, I would like to ask you to have a continued interest in the human rights for the disabled. And Attorney Yam, you are the member of the organizing committee for the Seoul Human Rights Conference. So do you think it would be possible for us to have an expanded opportunities for the human rights of the disabled? Yes, I am the member of the commission, but I haven't been in full charge of planning this human rights conference. But at a municipality level, human rights issues related to the socially vulnerable and the social minority are communicated through the commission, and we also try to put in place countermeasures that could be executed by Seoul Metropolitan government, and Seoul City also has been making recommendations concerning the human rights for the mental patients, and we also conducted the status surveys of the field, and all these activities can contribute to the enhancement, to the improvement of human rights for the disabled with mental illness. And it was in 2004 and 2005 that we started to raise the issue of human rights for the disabled, not mental disabled, I mean. And since then, by then, sexual violence and the infringement in human rights at the facilities for the disabled were quite severe. So I tried to get rid of those infringement and violations, and 15 years have passed, and now we can try to pass the support act for the support of the institution. And also in 2017, a mental health region act was enacted, but as indicated and highlighted by other discussants and presenters, the welfare system of local communities are not well established, and budget is not reflected, and that's why we have been working on this really hard for the past 10 years, and we have to see 10 years ahead. I wish that all relevant people can join forces and minds so that we can create the solidarity. Okay, Mr. Shin, would you please make a concluding comment?
아까 박종원 회장님께서 저희 센터
Well, Mr. Park has just mentioned about a media coverage for our center. Well, if you look at the articles, how they are formed, well, in that area, I think that Mind Post should take a leadership, and our center of Songpa Support Center for the mentally disabled, we will be helping you when Mind Post is leading the way. And Seoul City kicked off Independence Life Center for the mentally disabled, and it has been supporting those people for the past 3 years. And I still see that Seoul City sees those people as subject to get healed. So still, medical point of view is prevailing in Seoul City. So I think that more active support is needed, and that solidarity with parents of kids with developmental disorder was so touching, and I appreciate it a lot, because whenever we see a support law for the people with this developmental disorder is passed, and I am sure that the role of their parents was quite paramount. So instead of categorizing the types of disabilities, but if we could have a category of independence level, then I think that's more of a right direction. So if you could help us, then it will be very much appreciated. Thank you. Yes, the solidarity for the mentally disabled and the people with developmental disorders, well, those subjects are touched upon. And Ms. Nam, would you like to have more comment? Okay.
김정은 기자님 같지만 우선 김종욱 대표님한테 먼저 마무리 말씀드리고
Mr.
기자님 마지막에
Kim Yang-gyun, you should be the last to make the concluding comment. And Ms. Kim, please. Well, the subject that I would like to present today was empathy and solidarity. We should have empathetic mind and solidarity for local communities. But just before you said that please fight with us, and please do the demonstration with us. Well, that's what we are good at. So yes, so we will join our forces with you.
근데 김정은 대표님 공자께서 뭐 투쟁까지는 안 하셨을 것 같은데 인을 이야기하지 않으셨을까?
공자야말로 제가
But Confucian theory wouldn't boast for fight. What do you think? Well, I think that the Confucian theory is focusing on the innovation of the society. Well, I was just confused that if I have misunderstood the theory of Confucianism. No. You read it right. All right, Reporter Kim, please wrap up this session. Well, it's quite a burdensome task given to me to make a summary. Well, I would like to make a short comment on people with developmental disorder and mental illness. And I went to Palestine last year and met a mother named Suha Nazar. And I interviewed her because she said that she had a kid with developmental disorder. Well, there was no special school for the kid, and the kid got kicked out of the school. So she decided to set up a school herself. So if it replaced that name, Soha Nazar, by Kim ... and if it put that case into a Korean one, I just found out that the minds of parents with the kids with disabilities are the same. So that's why, listening to her story, that I should make more media coverage about those people, parents and kids alike. Well, returning to the documentary you saw just before, it was part of the series. We made 3 short video clips because we wanted to talk about comprehensive equality law for the sexual minorities and immigrant workers and the mentally disabled. And there's a anti-discriminatory law, but there should also be a comprehensive equality law so that we can have a legal foundation for the first stipulation of the Constitution that every human being is equal. And as mentioned earlier by Mr. Park, yes, there should be criteria or standards of media coverage, but every media corporation has their code of ethics. If we are pursuant to those codes, then this kind of yellow journalism would not be seen this much these days. So if we could have national institutions joined into this gathering, then it would be of a practical help for us. Thank you very much, and I will make my personal effort as journalist as well. Well, thank you. For about 2 years, we listened to 2 presentations and 4 discussions, and through this, as suggested by Seoul Human Rights Conference, I wish that we have ignited the importance once again of human rights of the disabled, and in particular the disabled with mental illness. And personally, this type of human rights conference should, I think, these type of human rights conferences should be held not only in Seoul but in other regional cities with the topic of the disabled and their rights, etc. Thank you very much for being with us until the end. And this rounds out session 3, Mental Health and Human Rights. And thanks to our viewers as well. Thank you very much, Mr. Moderator. And the second day, the third session of 2020 Seoul Human Rights Conference is over. With the title of Mental Health and Human Rights, we have looked around the current status of human rights of the disabled with mental illness, and we also discussed the solutions that we need to seek for. Well, thank you very much, Moderator, and discussants and the presenters for your active participation. Ladies and gentlemen, from yesterday till today, for the past 2 days, we have been holding 2020 Seoul Human Rights Conference. I hope you have enjoyed it to the fullest. And under the title of Role of Municipalities in Times of COVID-19, we shared the different cases, and we also contemplated all together on the future direction. And today also, with many experts from overseas, we touched upon different subjects in each session concerning the elderly and human rights information and mental health and human rights as well. And many online viewers gave us feedback and opinions, and making this conference a venue for better communication. And so Metropolitan City will also make its effort with a generous embracement so that it can contribute to the enhancement of human rights of all citizens, and so to be a benchmark for other cities. And next year, we wish that we could be able to share successful cases of human rights protection. And thanking you once again, we will see you next year. Thank you.